So my talk, it's really about the evaluation of, as we have described in detail, the diagnosis of non-alcoholic fatty liver disease. And thank you again for joining us for this fatty liver symposium, and it's oriented for patient education. As I said before, my name is Maria Lagarde, and I'm part of Einstein. All right, so what we will focus on learning today. So first is what causes fatty liver. Second thing that I want you to take as a take-home point is how to recognize other conditions that are commonly seen with fatty liver, how to define liver fibrosis, what is fibrosis, and we'll go in detail into that, and what methods or tests can your doctors use to recognize fibrosis. And then we'll touch base with some of the treatment strategies, but then that will go further into that as the program progresses. So your doctor has recognized fatty liver disease or fatty liver in some form. Now what? So first, let's say, how does a doctor recognize that fatty liver is present? Well, there's a few ways. One is your primary care practitioner may have seen abnormal liver tests, as we spoke before, and we'll touch base as to what those abnormal liver tests are, whether it's elevation of level A or T, or you were in the emergency room for something different, and you had a CAT scan or a CT scan of your abdomen, and there is a read or a diagnosis of fatty liver has been made. Other ways that can be identified, well, your doctor may be actively looking for it, right? You may have all of these conditions that we've talked about: diabetes, high cholesterol, high blood pressure, excess weight, and your doctor is concerned that you may have this condition, and so he considers sending liver tests or images to see if this is your condition. But now it's identified. There is presence of fat in your liver in some form or another. So what are we supposed to do? So first is what your doctor and you need to know. So again, there's a difference between the type of inflammation or fat that we can see in your liver. And as Dr. Haluga was mentioning, it starts with the presence of there's fat, and that fat could just be sitting there, not causing any problems or concerns. But then that could potentially lead to active inflammation. Active inflammation of the liver then leads to scar tissue deposition. And with that, as it advances, severe scar tissue, then the presence of cirrhosis. And it is important to identify in which part of all these four patterns you are at the time of diagnosis. And this is what we will focus on. So it is important to know these different steps in the disease, and it is important to try to identify as soon as possible in which one of these categories you and your liver fall. So how does the liver relate to the rest of the body and the rest of your health? Well, we have talked to this at length. So the liver is not alone, and it's very well linked to the rest of your body. And so having fatty liver predisposes your body for other conditions. Cardiovascular disease, as Dr. Banca will talk at length later on, the risk for strokes or cardiovascular conditions, diabetes, kidney disease or kidney dysfunction, high cholesterol, but also some others that you may not recognize, like polycystic ovarian disease in females, in women, or sleep apnea, which is also associated with excess weight. It can also link to a high risk for cancer or malignancies. And lastly, joint conditions like arthritis. And you may find that your doctor not only is looking for the presence of fat in your liver and trying to identify in which of these categories you fall, but also to try to identify some of these associated conditions, because we know that targeting each one in combination with the excess in the liver fat or the steatosis and steatohepatitis can lead to improved outcome in all of them at the same time. So again, we try to put it all together and identify which conditions are linked which are playing the biggest role. And by controlling one, we may be able to help the others and so forth. So the same way they're all interconnected at causing disease, also controlling them in an interconnected way, it's also important to treat fatty liver. So again, we talk about this metabolic syndrome. So first, let's recognize that a syndrome is a combination of illnesses that happen together, or conditions that happen together in the body at the same time. And it is a combination of all these diseases that we've talked about, including high cholesterol, high blood pressure, fatty liver, diabetes, and excess weight. And they play a significant role in the presence of fatty liver. We also don't treat this condition alone. It's very important to identify, as you'll see, that there are multiple. As hepatologists, we don't work alone in this disease. Why? Because we're not experts in diabetes, in cardiovascular disease, in weight loss. We're not weight loss specialists. So we need the help of the entire multidisciplinary team, which you see reflected here, to help us not only take care of your liver, but also to help really improve all the parts of this very complex condition, the metabolic syndrome. All right, so let's start by what are some of the things that your doctor would ask you to obtain as a basic once this fatty liver is identified. So we talked about getting some simple blood work, and that could include your blood counts. Specifically, we look at the platelets because they are some cells that help clot or form clots inside your body, and as they go down, they could potentially go down and be a marker of more progressed liver disease. Then we talked about the liver tests. We look at the alkaline phosphatase, at the bilirubin, the albumin, but as you have heard before, AST and ALT are some very important markers as to whether inflammation is present or not in your liver. Coagulation factors. The liver has this very important job of producing proteins that help you stop bleeding when you start to bleed for another reason. And so when these proteins are not being made because the liver is sick, then your coagulation markers, including this particular one called the INR, would increase or go up. And so it's one of those that tells us the liver is not really doing its job as it's supposed to. We also, as I said, we look for all those associated conditions, including thyroid disease, diabetes, and other markers of glucose intolerance. And lastly, we want to make sure we look at the cholesterol and the lipid panel. Again, looking for clues that there are associated conditions that need to be treated at the same time and that are going to help improve your fatty liver as well. Then that's from the type of blood work that we would do. Then we take that information and we use some what we call fibrosis calculators. So I'll explain a little bit more what fibrosis is in the next couple of slides, but basically means there are some calculators or scoring systems that we can use with your regular blood work and sometimes with more advanced blood work that can give us a hint or an idea of where in that process you are of scar tissue, whether it's minimal scar tissue or have you progressed or has your liver progressed through that sequence and there is more scar tissue than we would expect. Some of them you may have heard about, you can see them online, sometimes you can even calculate them yourself. Very commonly used is the FIB-4 score, which takes simply into account your age, AST, ALT, and platelets, or the NAFL fibrosis score, which includes a couple of other parameters. And then there are some that are proprietary, meaning they belong to the specific blood work, so we don't have the specific calculations or formulas that give us an idea, but they can be very accurate as well at predicting how much scar tissue there will be in your liver. But as I said, we have to look for other reasons why your liver has become fatty outside of the metabolic syndrome. So yes, we have to look for those conditions of the metabolic syndrome and we have to try to diagnose them and treat them accordingly. But we'll also have to look for things outside of that that could be worsening the condition. So one is alcohol. We talked that, it's called non-alcoholic fatty liver for a reason, and it's because alcohol liver disease looks very similar to this. And sometimes the only way to really determine it is the amount of alcohol that a patient reports that drinks on a regular basis. So it's very important to really take a look and see what your alcohol consumption is, and you may have a long discussion with your doctor regarding this when fatty liver is identified. We'll have a great talk with Ryan later on and kind of to tease out some of those details of what your doctor may ask or how we would find out this information. Then we have to rule out other problems that may cause fat in your liver. For example, viral hepatitis. Some specific viruses like hepatitis C can lead to an increased amount of fat in the liver. And so your doctor will for sure test for this to make sure it's not present. Medications. So there are medications that we know cause increase in the increased fat in the liver with inflammation. Some of the most commonly identified ones are steroids or prednisone, methylprednisolone. So patients who take these medications on a regular basis may find themselves with elevated liver enzymes and fatty liver. And it's important that your doctor really considers this as an option. Then there are others, breast cancer medications such as tamoxifen can be found, or cardiovascular medications like amiodarone, seizure medications, etc. So really having a good review with your doctor as to whether any of the medications you're currently taking can be causing the problem is very important. Lastly, there's a few other things that we usually test and check. Thyroid disease, specifically low thyroid, can lead to accumulation of fat in the liver. And so other metabolic diseases and endocrinologic conditions can be associated. And lastly, there's some rare genetic conditions that your doctor may want to test depending on your family history or your predisposition, where you come from, or your age, as to whether these diseases are possible. And so these are some of the ones that we would consider that can lead to excess fat in the liver. One is excess iron or hemochromatosis, excess copper or Wilson disease in very young patients, as well as deficiencies of specific enzymes that help metabolize fat, such as LALD deficiency or alpha-1 antitrypsin, which is a molecule that accumulates in the liver. In any case, rare genetic conditions, your doctor will look into your history, your family history, and see as to whether these conditions need to be investigated. Let's now focus on fibrosis. So we said that, yes, your doctor now has identified the presence of fat and has ordered some basic blood work and is starting to think about looking for fibrosis or scar tissue. Let's start by what is liver fibrosis. So fibrosis is the presence of scar tissue that accumulates in the liver after inflammation. So it's your body's way of healing, basically forming a scar, kind of like when you cut yourself and you have a big red inflammation, and that then leads to change in the surface of the skin. The same thing happens in your liver. If it's inflamed and red and angry, as it heals, then it leaves down a different type of tissue, and that's what is called scar. And as that builds up, that's what we call fibrosis. And it does prevent the liver from working properly. So it is really important to recognize it because this is the start of further problems. So how do doctors help determine the level of fibrosis? Well, we have different ways, and as you'll see later on, but some of it, what do these numbers mean? 1, 2, 3, 4, how much fibrosis I have? Well, that data comes from taking liver biopsies of patients with this condition and seeing, well, as you can see in this picture, it can start with minimal amount of scar tissue or no scar tissue at all, just following the vessels around inside the liver. And then as that progresses and progresses, it starts to form these links between the vessels inside the liver. And you'll see these like big spidery webs that then become thick, band-like. And this is when we start to worry, because this is what we call advanced fibrosis. And the more scar tissue there is, the harder it is to then have a normal liver, because this scar tissue has taken over some of the significant function and portion of the liver. And so it's really hard to then go back to normal. So who is at higher risk for this happening? Well, we talked about patients who have metabolic syndrome or this combination of diseases that all go together. So a high excess weight. So doctors like to calculate this relationship between your weight and your height. And that gives us a number, a BMI, which is once it's above 30 is when we start to consider this as a problem. Diabetes, high blood pressure, high cholesterol, older age, again, more time for this liver to have had inflammation and heal over time into scar tissue. Elevated liver enzymes, because we suspect that this is a marker that there's ongoing active inflammation in your liver. And then the presence of fatty liver on images also is a risk factor. But then the highest risk, so women as they reach menopause, excess weight, diabetes, but then unfortunately of Hispanic heritage are at the highest risk. So fibrosis again. So we talked about some of the ways your doctor may look for fibrosis. Non-invasive testing, that means testing that doesn't really require much from the patient or puts them at risk, like basic blood work, or this combination of scores that we talked about, like the FIB-4 score or the NAFLD-FIB score. Then there's specialty labs. So again, not very invasive, doesn't require much from the patient, but may be a little bit more costly, or may go to a specialty lab in order for it to be performed. And some of them are proprietary. So again, we don't know the exact equation they use to tell us how they calculated the presence of fibrosis, but we get a result. And then we can tell whether you're in a lower range of fibrosis or in a higher range of fibrosis. Then there's some other testing that we do, and that you may have had it done in the office if you came to see us, or you may hear about it. It's something called elastography. And this is also non-invasive, meaning it doesn't require much from the patient, where we take a look at your liver either in image way, an ultrasound, or a simple test that we do in the office to tell us about the degree of scar tissue. There's multiple ways. There's transient elastography, which is done in the office, doesn't really include a lot of pictures of the liver. And then there's ultrasound-based or MRI-based. And so again, different ways we can assess for this. And then lastly is a liver biopsy. And sometimes it really comes down to requiring a liver biopsy to tell us the degree of scar tissue, but not everybody needs a biopsy. And so it's a final direct tissue evaluation, and it's not perfect. The liver is a very big organ. A biopsy is just a very small sample of it. And so it doesn't always necessarily tell us 100%, but it's the best way we have of assessing for scar tissue or fibrosis. Let's talk a little bit about explaining elastography. So your doctor may have said, or might have recommended you have this type of testing. This is just one of the ones we have in our repertoire of things we can use. You may have seen a report like this, so it is important to understand why we use this. So basically, elastography is a medical image technique that maps the elastic properties and stiffness of tissue. So basically, and that's usually done through vibration. So what that means, and those may be big words, is that they're using vibration and the speed at which that vibration flows through the tissue to tell us whether that tissue is stiff or soft. And the amount of stiffness tells us the degree of scar tissue. So it's really a wonderful tool that comes from physics that tells us, the stiffer a tissue is, the biggest concern for scar. And it's very well studied in patients with fibrosis of the liver to give us a range as to where they are. So it's a wonderful tool that does not require a liver biopsy. And so there are other ways to measure scar tissue. Like I was explaining before, some may be more specific, and so better looking at the through an ultrasound at the liver images and taking a look at that area, or even an MRI. So there is some more advanced, and sometimes they go up in cost, or they may, why we would choose one study versus the other is really a decision that we make together with our patient to try to figure out what test will give us the best information. And sometimes we need a combination of tests to really decide where is my patient in that scar tissue or fibrosis range. So do you need a liver biopsy? So again, we don't necessarily need a liver biopsy for all patients. who we are concerned for scar tissue or fibrosis. And we have ways of just kind of putting patients in buckets and saying this patient is less likely to have advanced fibrosis and we can focus on other problems. This patient has a high likelihood of having fibrosis and we should really be hunkering down and focusing on this particular patient regarding their liver disease. And so how do we do that? How do we make that decision? Well, we start with the simplest test first, right? We check your blood work, we look at this fibrosis scores, and if those are very low and very low probability of fibrosis, then those patients can be managed by their primary doctors. And what we say is, we like to look at these similar tests every 1 to 3 years, and we look and see if there's progression or more fibrosis, and we work on all these different things that we'll talk about throughout today. But then if those tests are showing maybe a red flag, hey, maybe there is fibrosis, let's look at this into a little bit deeper. So the basic blood work and the fibrosis assessment start to show maybe, yeah, we're looking at fibrosis. Then we do some of the more advanced testing, like the elastography. A FibroScan in the office is one of the proprietary tests that we use, or the MR and elastography. And so with that, if those, again, if we confirm that those have low probability for scar tissue, then again, we focus on risk factors, we treat the underlying disease, and we check for this scar tissue every 1 to 2 years. Again, if no, the secondary test is still concerning, or there's discrepancy between the elastography and the test, and we don't really know which one is playing the biggest role, then those are the patients that we really consider for biopsy. And again, we do a third layer of testing before we do the biopsy because it's not a completely benign test. Other reasons to do a biopsy, well, there is a concern for other conditions that could be playing a role, whether it's viral hepatitis, autoimmune liver disease, or some of the genetic conditions we mentioned earlier. And we're not sure which one is playing the biggest role, or if there's one or the other or both, then those are the patients that we really consider for liver biopsy. And then lastly, participating in a clinical trial. So we, at both institutions, we have a multitude of clinical trials that really look at potentially treatment strategies, medications, or different approaches to patients with fatty liver. But we do have to make sure that we have the right patient. And so sometimes for that, we do require a liver biopsy for initiation in a clinical trial. And so that you may, as you hear more about the possibility of a clinical trial, a biopsy may become necessary. So then what do we do with all this information? Again, we put patients into buckets. Are you low risk, rising risk, or high risk? A patient with low risk, this is the ideal situation. This patient can go back to the primary care physician. We reassess for scar tissue every 1 to 2 years, but we continue, this is very important, we continue to work on the risk factors for fatty liver because that has already been identified. So we work on management of weight, we work on diabetes, and we work on cardiovascular prevention. However, the patients that we identify that are, at higher risk, then these are the ones that need specialty care. These are the ones that we'll see more often in the clinic, that we'll have this big multidisciplinary team of people trying to help us figure out which disease is playing the bigger role and how can we best, as a team, help this patient achieve their goals and trying to reduce the inflammation, because the biggest goal is to stop progression of scar tissue, because we know that if the scar tissue progresses and leads to cirrhosis, that's what we want to try to avoid. So the idea is to halt or reverse, ideally reverse and get that patient back to normal, but if not, at least halt and stop the progression of disease. And so this is why we focus all of our energy in these patients who are the highest risk. But what if I have cirrhosis? It's possible that at the time that you come to see us or be evaluated by your doctor, well, unfortunately, we identified advanced scar tissue and you have cirrhosis. So some of the things that we can tell is, again, elastography can help determine this test, or FibroScans or elastography, the stiffness of the liver, can help us tell if you're at high risk for complications. Some of the complications include portal hypertension or high pressures inside the abdomen. I'll tell you a little bit about the symptoms to look for if cirrhosis is a concern. It also means that you will have to start screening for liver cancer, and we would do that every 6 months with blood work and an ultrasound. And then lastly, we still continue to address the risk factors, because even with cirrhosis, if we treat the underlying disease, we know that the likelihood of progression is less. So even if you have cirrhosis, we still want to hold the progression where it's at and try to limit. Getting almost close to time, but just wanted to mention some symptoms of advanced liver disease. So things to look for: excess bleeding, ascites, meaning excess fluid that starts to build up in the abdomen, excessive bruising, again, signs of bleeding inside the tissues, confusion, that's something we call hepatic encephalopathy, or again, liver cancer. So if cirrhosis is identified, these are some of the symptoms that your doctor will be asking. And then lastly, treatment. So treatment starts now. The second we identified fatty liver, that's when your doctor should start to counsel you and discuss treatment options. And what are those treatment options? Well, basic things come first. So lifestyle interventions, talk about your weight, talk about management of your cardiovascular risk, and talk about diabetes care. Medications, we'll hear quite a bit about some of the options that are available, but most importantly is even patients at low risk, but that have presence of fat, those are the patients that we still try to target to limit and stop progression. Again, we don't do this in an alone fashion. We work with a multidisciplinary team, and it's very important to recognize that everyone brings something to the table to help take care of you in a holistic way or to your whole body. Okay, any questions? Well, we'll have questions at the end, and then I'll give the floor back to Dr. Halegua.
Hi, thank you, Dr. Lagarde. That was a great presentation. I think, so important to hear that we don't always have to do a liver biopsy, and that we have so many other new techniques to really accurately make a diagnosis and start treatment. Well, it's my pleasure now to introduce our next speaker, Emily Rubin. Emily is a licensed clinical dietitian with our Division of Gastroenterology at Thomas Jefferson University Hospital. She's won multiple awards and has really been key for our Fatty Liver Center. So Emily, I'm going to turn it over to you, and thank you for joining us today.
So my name is Emily Rubin. I'm a dietitian at Thomas Jefferson University Hospital, and I've been with the practice for over 20 years now, working with Dr. Halegua and our team of doctors, nurses. It's our team at Jefferson. So we're going to talk about lifestyle modifications, which is one of the most important treatments when it comes to fatty liver and weight loss. So we're going to try to discuss today the treatment, the lifestyle diet. We're going to go over a little bit of the nutrients, breaking down carbohydrates, fats, proteins, coffee, a little bit of positive with coffee, vitamin E, some of the dangers of some of the herbal supplements, sodium, and we'll talk about a few of my patients. So again, the treatment of fatty liver disease, we're looking at weight loss as the primary treatment, and that would be lifestyle modification, which I would be working with. And it also helps to treat all the other different conditions that Dr. Halegua and Dr. Lagarde talked about, which was the management of type 2 diabetes, high cholesterol, and helps to treat all of these conditions, this whole metabolic syndrome. So some of the dietary indications for non-alcoholic fatty liver disease, what we recommend, and we'll go over this specifically, is whole grains, different kinds of fats. So there's different fats such as the omega-3 fatty acids found in fish, monounsaturated fats, vegetable protein, different kinds of fiber, vitamin E in coffee, and things that we want to avoid are simple sugars, which is fructose, so that could even include fruit juice, saturated fats and trans fats, and animal protein, which is the red and processed meat. And this was a study that was done in 2019. So let's get more specifically with the kind of fats that we would want to eat or possibly avoid. So we have saturated fats. So saturated fat is only found in animal products. So that's red meat, that's high fat dairy products. I will tell you, because there's a big trend with the coconut and coconut oil, coconut actually is the only plant-based food that has saturated fats. So on that coconut health trend, it's actually something we don't want to do. So the consumption of that is discouraged. So the healthier fats is the monounsaturated fats. So that's olive oil, avocado, nuts. And again, we want to consume them moderately because even though they're healthy fats, they're still high in calorie. And then some of the polyunsaturated fats, which are they're found in the vegetable oils and the cottonseed oil. So a few of them we want to avoid. And then the polyunsaturated omega-3 fats, which they're actually the healthy fats, that's found in a lot of the salmon. It's also found in flaxseed, some eggs, and some lean red meat. And then trans fat is one of the worst fats because it actually, a lot of the labels, they've now removed that. Trans fats is when things are partially hydrogenated, where they become thicker, like butter. But what the problem with the trans fats is they actually increase our bad cholesterol and decrease our good cholesterol, where we want that reversed. So, what meat is actually best for us? Vegetable-based chicken or red meat. So the thinking behind that is we want to always try to choose more plant-based, which is the plant-based burger. But there was a study showing when you cook, even if it's chicken or red meat, when you cook it at a really high temperature, it actually can have an effect a little bit on, like when you fry foods, on fatty liver as well. So it's more important to, when you have these foods, not necessarily to fry them or eat them at a high temperature, to grill them. And if you want to choose either red meat or chicken, choosing the lean chicken. And if you get ground chicken, I always recommend the ground chicken, which is like the 98% lean ground chicken as well, because sometimes they grind the dark meat in as well. So what kind of diet, are we looking at? And Dr. Halegua, specifically explained, it's really interesting. If you lose anywhere from 5 to 10% of your weight, you can actually reverse fatty liver. So, we see here in our little guide here, a 7 to 10% weight loss. There were 3 diets that were studied: low carb, low fat, and Mediterranean diet. But you see, following that diet and getting that weight reduction, we can see how it starts to reverse itself. And the Mediterranean diet, which we're actually going to talk about, that's the high fiber, eating, more fish, more vegetables. It's a lower cholesterol, low sugar diet. The only time, fatty liver can't be reversed, and I don't know if we will get into that, is if it turns into, sort of a liver cancer, then it's a little bit of an issue. So again, the treatment: weight loss, weight loss, weight loss, weight loss. So again, it's a lifestyle modification diet. In terms of the restricting carbohydrates and Atkins diet, we're going to talk a little bit about the dangers of that, but increasing Mediterranean diet, avoiding the sugar. And then if you're going to have coffee, 2 to 4 cups a day. But again, we don't want to be adding sugar and cream to it. And then exercise. So this is interesting. This is actually a scale here that I have at work. It's, on the exact perfect age for someone my age, height, and my name. A lot of our patients, say that. But what's really interesting about this scale here is it actually tells you how many calories you can eat per day. And people are like, I didn't realize, you don't need very many calories. You're thinking you need, 2,000 calories, which every food label says. You actually only need, some patients only need 12, 1,400 calories, at a resting. And then we have to even subtract a little bit of that if we want to see weight loss. So again, we see that 7 to 10% weight loss. Again, we don't want to lose that weight like tomorrow. People come to me, how do I lose 50 pounds in 2 days or 2 weeks to, fit into a dress or whatever it may be. The whole point is we want to do it. It's a lifestyle change. It's not a diet. So we're looking at, no more than 1% of your weight per week. So let's say, you weigh 250 pounds. You don't want to lose more than 2.5 pounds per week. That being said, sometimes, initially when you start a weight loss program or lifestyle, you may lose a little bit more in the beginning, but then it will start to taper. So another thing is 80% of patients with or without metabolic syndrome, when they've done a study, were showing that they were eating more than 12 teaspoons of sugar a day versus the 17% control. So, 12 teaspoons a day, that's a Pepsi right there, a 12-ounce can of Pepsi, if you get an idea. This is a little bit of an older picture here. These are my boys when they maybe were about 10. We went to the Sixers game, and if you look at that slice of pizza that they're serving, it's basically the size of them. So you can see how big that is, and that's like 1,000-calorie slice of pizza. This is the problem: is the portions get so big. And if we look at the soda, you can see all the different teaspoons of sugar. One of my sort of fatty liver 101: never ever drink your calories, including sugar calories, because first of all, the amount of calories you could drink. I mean, for this 24-ounce Coke, or you could have, a turkey sandwich, with lettuce, tomato, on whole grain bread, and it would be so much more filling than drinking the soda. And then we're at that Halloween time. This was last year. We had a Halloween contest with the chief medical residents, and you see how they actually chose to dress all as candy, which I thought was really cute. What the other bigger issue is the portion control. that we're dealing with. So we're looking at, bagel 20 years ago, was the size of like a hockey puck. And now it's like, I don't know, 2 hockey pucks. I mean, it's literally equivalent to like 4 or 5 pieces of bread. So I tell my patients, would you eat 5 pieces of bread at one time? Most of the time they'll say no, but that's the problem when you eat a bagel. And the same thing with the cheeseburgers, that everything's getting bigger. So, one burger years ago, like the kid size burger now is considered, or the regular size burger now is considered almost like the kid size burger. So you can see everything's doubled in calories. And what about spaghetti, pasta? When you go to a restaurant, pasta is a really cheap food. So you will get a lot of it because people want a lot of value for their money when they dine out, but they will basically, you could feed, the size of your family, and then some. And then soda, again, how the sodas have gotten so much bigger, and even the French fries too. This years ago, it was a kid size fries was the serving. Now it's, the large one. So it's twice, 3 times the calories here. So let's talk about some of the different diets. According to the U.S. Health and World News Report, the best overall diets are the Mediterranean diet and the DASH diet, which we'll talk about, which is adding a little bit more, a lower salt version of it. The MIND diet, combining a lot of the omega-3s, and Weight Watcher diet. And if we go through all these different diets, the one thing that is all similar is that none of them actually restrict or take away a whole food group. Like, for instance, these diets that you might read online where you can't have any carbohydrates, or you can't have any fats, or you can't, restricting. None of these restrict. They all sort of give you what you can eat in a portion control. So let's talk about the Mediterranean diet, because we just know the benefits of this particular diet here. So again, it improves, the metabolic conditions related to fatty liver, heart disease, all the positive part of obesity and fatty liver. Basically having our sweets less often, fish 2 times a week, whole grains, and then the physically active, low stress. And what's really interesting is like sharing a meal is really important too, especially when you dine out. It may help save calories. The thinking behind this is years ago, we actually had a fatty liver speaker. And the difference is why it doesn't work in the United States as well as opposed to the actual Mediterranean is because we don't follow the whole lifestyle. We're not walking every day to buy our food. We're not cooking all fresh food. Just the American lifestyle is just a lot harder than what it is in the Mediterranean. So let's talk about plant-based. So basically, the Mediterranean diet is taking the next step and adding more plant-based foods to the diet. So we're looking at not necessarily going vegan or vegetarian, but just, substituting a plant-based meal 3 times a week, maybe adding more beans, adding more, fresh fruits and vegetables, not necessarily going, vegan, but just having a plant-based meal, in your diet, 3 to 5 times a week. And they've shown studies that basically, if they have this, it could decrease the fat loss in the liver and reduce fatty liver by half. But that would also be combined with weight loss as well. So again, we have the plant-based diet here, which is, the whole grains. Again, we want to choose brown rice, barley, quinoa, increasing more vegetables, fruits. We're adding beans, and again, adding the high fat, the healthy fats. So then you'll look on the internet and Instagram and see plant-based versus plant-based. Well, some of my patients think plant-based is, is mac and cheese, French fries, 3 pieces of broccoli and a cookie. That's not going to work. So we're looking at, again, quinoa, this is like squash, avocado, beans, this kind of salad, which, many places actually sell this like a sweet green, and, even like a salad works. There's ways to get these foods, or even meal prepping. So this is actually one of our fellows here, and she runs an Instagram, and she has Dr. Paula Carpo does a whole thing with plant-based and plant-based geared towards kids. So, it can look very appetizing, and it's very tasty and obviously very healthy. So again, the whole thing with the fad diets, they've done studies, and the whole point of these diets, Atkins, keto, paleo, everybody loses weight on the diet. Any one of these diets, if you follow, you're going to lose weight. And with weight loss, we're going to see, reverse of fatty liver. The problem is it's not a lifestyle change where you're going to wind up with possibly gaining the weight back. And that's what we don't want. So this was a patient here, interestingly enough, who was following a keto diet. She came to me. And if you look, she followed the diet, and her cholesterol went up to 591. So normal cholesterol should be less than 200. Her triglycerides actually were good because she was eating, no carbohydrates. Her good cholesterol was good as well because she was eating so much fat. But her LDL cholesterol, which is the one that really can cause heart disease, went up to 454. That's supposed to be less than 100. So this is extremely dangerous. This diet of 70% fat, 5% carbs, 25% protein. I can do a healthier version of that, which is including healthy fats, but carbs aren't necessarily bad. It's calories and the kind of carbohydrates you're eating. And eating this actually can be worse on the liver. Again, we see that weight loss, but long-term use of this can be very dangerous for heart disease. So what about intermittent fasting? We know that's the hot new diet that's come out. And they actually retracted the study on this diet in terms of where you only eat, between 8 hours a day, if it's 12 to 8, or some of my patients will choose 5 to 12. The problem with this is the reason why people lose weight is because they're restricting their calories. So they're eating less. And it's only giving you a time frame, so cutoff time. But again, the reason why they retracted is because they're not seeing a whole lot of positive results. And patients, if you're going to choose to eat your calories at 10 o'clock at night, that's not going to work because our bodies tend to slow down then. So, what works, again, not a diet, a lifestyle change. We, a little bit of the higher protein, leaner, lower fat, but healthier fat, 30% fat, 30% carb. Eating breakfast, again, studies show, when you eat breakfast, some people say, oh, I'm hungry all day, but actually eating breakfast does show some positive, because then basically the hunger always catches up with you. High fiber, drinking 8 glasses of water, not rewarding yourself with food and meal prep. So this is basically the fatty liver chart, looking at 40% fruit, vegetables, 25% complex carbs, lean proteins, healthy fats. So we have our 5 to 8 glasses of water a day. This is a little bit of a better pyramid. Our fruits and vegetables still at the bottom, whole grains. Our chicken, turkey, fish, 1 to 2 servings. So again, nutrition is very visual, and I can't just I'm spitting out a bunch of sayings to you. What does it that actually mean? When patients come to me, my job is I want to give them that substitution so they don't feel like they're restricting themselves and they can still have, if let's say, bread. So there's some really nice products here. This is the 647 bread. It's one of my favorite breads. It's a lower calorie bread. It's made by Schmidt, but it actually is high fiber and tastes really good. There's different kinds of, high protein, lower in carb wraps, rice, cauliflower. These are all the different pastas that have been out there. I did a whole thing on, I do some media stuff on that. And this is like a cauliflower pizza. And then what about different kinds of snacks? You want ice cream. Well, they make these, 100-calorie Weight Watcher or Yasso bars that taste really good, don't have any artificial sweeteners in it. Greek yogurt, 100-calorie popcorn, nuts, things like that. And then, you can have your cake and eat it too. These are actually my twins now that are 17. But, I found there's healthier ways to make this. This was actually a brand here that makes it says low carb, but we actually add like yogurt to it and milk and, egg whites, and it makes this really nice cake. And then what about the air fryer? Who doesn't miss, fried foods? I did something with Allie Gorman a few years ago and showing, I actually showed the calorie difference of making like my own breaded chicken versus like, Chick-fil-A or any of the fried chicken places. And it's a difference. You save 100 calories and like 10 grams of fat. Same thing with the mozzarella sticks. This was, I actually did a whole thing with cauliflower and like even veggie chips. So there's definitely options. And the air fryers have really come along and they give you that taste without the fat. And then what about sodium? We try to watch sodium too. Sometimes it's more issues with high blood pressure, advanced liver disease, but 1 teaspoon of sodium has 2,400 milligrams of salt. So that's like, like your pinky nail of sodium is your whole day's worth of sodium. So again, we want to really try not to add salt, not adding salt to your products, watching the condiments, you don't have to add salt when you cook pasta, cereals, and things like that. Apps are really good. There's the Lose It app. There's the My Fitness Calorie app, which is really good. And I work with that with patients as well. Talking about like typical calories and fat in a day, again, if patients go to Dunkin' Donuts, I don't want to tell you can't eat out. Let me make a substitution for you. Let's choose, the English muffin instead of the bagel, maybe get rid of the blueberry muffin, as well. And then in terms of and using maybe like an egg, they have these little egg wraps. And then when it comes to all the different iced coffees, some of them can go from 250 to 500 calories. We can substitute almond milk. They have like a flavor shot instead of the sugar. And some other things that we discussed. I have different recipes for like these little mini frittatas, using a sandwich with like the low carb bread, and some of the different snacks that we discussed. These are more meal plans. And then what about alcohol? Again, not only alcohol is an issue with fatty liver, because they showed 41% of patients with no alcohol use had actually reduced, fat in the liver versus 68% who had 2 drinks a day. What about the calories? And you're looking at a Manhattan or a margarita or a pina colada, some of them were 500 calories for that 1 drink. So we're looking also at the sugar content. What about exercise? Again, both exercise are fine. This is my neighbor who's Alex, 75, who basically runs, 5 miles every day. We don't need you to do that. And these are my kids who play, intense soccer and baseball. But we're just looking at, any kind of exercise, if it's walking 30 minutes a day, 3 times a week, for 12 weeks, any moderate intensity. And if you don't do anything, and if you just walk, 10 minutes a day, anything is definitely positive for fatty liver. This was a little bit about caffeine. I'm going to move along a little quickly here, but caffeine basically, again, they've gone back and forth. It's the 2 to 4 cups a day. For instance, 1 cup of Starbucks has about 300 milligrams of caffeine in it. So that's all you would really need, to get the benefit. Again, it's just adding a lot of sugar to it. And then vitamin E, I don't know if anybody's going to discuss that, but sometimes you'll see some supplements for that. You don't want to take more than 800, but if you have any kind of diabetes or pre-diabetes, it actually can be dangerous. And what about yo-yo dieting? That's the biggest issue here. It's like Oprah Winfrey, who's basically gone up and down a million times. The issue is sometimes going up and down actually can not be great for the liver, but it's better to try to lose weight than never to lose weight at all. But the whole point is, again, developing a lifestyle change. So again, our lifestyle approach here is, our calorie restriction, which is 500 to 1,000 calories a day, doing the lower fat, but the healthier fats, the moderate carbohydrate, but choosing whole grains, and again, avoiding the ketogenic diet, exercising, and limiting, sugar. And then we can see the different kinds of, improvement over 52-week intervention with the 5%, it's like 90% where it does get better, your liver. And then I just wanted to say real quickly, there's no magic pills for weight loss, because that's a big thing. I know Dr. Halegua did, wrote an article a few years ago about a patient who took green tea extract. You'll see a lot of this in the news. And then it came out again in the British Medical Journal. Again, none of these extracts are regulated, not only green tea, but anything else that you're going to see. And it's metabolized to the liver, and it can put you into liver transplant or liver failure. So, people will, they'll be, taking these green tea extract pills, the high dosage actually, again, can put your liver failure. When you're walking around drinking those huge containers of green tea, it's like the maximum dose tolerated by humans is 24 cups of green tea, which sounds like a lot, but if you go to Wawa and buy those half gallons, you may see some issues. And then this was one of our nurses here that worked with us. And he was 20 years old with fatty liver, pre-diabetes. And you can actually see here that, he changed his diet. We worked together. He was 300 pounds. Now he's 170 pounds. He's run the Broad Street Marathon and competed in multiple events. And then this was another patient of mine that was sent by one of our fellows that's now a physician. We were actually in nationally with this article. She came to me during COVID, this girl here, and 26 had, liver disease or fatty liver, hyperlipidemia, high cholesterol, all those things. She started at 240. We got her down, within a year to about 170 pounds. Family history of metabolic syndrome. Her people had been on, had weight loss surgery. She just didn't want that. So we meal prepped. But if you look at her here, she's exercising here outside because the gyms were all closed. But I worked very closely with her, and we got her down. And now I think she got married a couple months ago. But not that it was for marriage, but it was just really important for her to lose weight, and she's done really well. And of course, it's Halloween time, and everybody knows, or my staff knows how I dress up every year. It's my favorite. So here, actually, ironically, here I was fatty liver. So I'm wearing actually one of my kids' costumes I made into like, I'm eating like burgers and cheesesteaks, and there's my cirrhotic liver. There's my beer that says Dallas sucks, but sorry, Eagles beer. And then I made this pumpkin cake here, which I think I did a TikTok that somebody may show. And this is our other dietitian, Melissa, here, that we, both of us see patients. So feel free to schedule with us. And sorry about the issues with our, the Zoom today, but I guess that's it. Thanks so much.
Oh, thank you, Emily. That was wonderful. We actually saw your TikTok at the beginning, right as the meeting was starting, but that was great. Thank you so much. I mean, I think you truly summarized, food is medicine. And I'm glad you brought up the supplements. So many things are advertised as quick weight loss supplements, and can potentially be actually toxic to the liver. So we need to be really careful, and coffee is good, and avoid sugar. Awesome. I want to remind everyone, actually, we'll be showing the phone number to contact, but you can schedule an appointment with Emily or Melissa if you'd like to get a personalized time to sit down and talk about your diet. And as Emily has told me, most insurance companies do cover several visits a year with a dietitian. So I would definitely take them up on that, that as part of your benefits. I'm going to now introduce our next speaker, who is one of my favorite colleagues and friend, Monika Shrodakar. She's a clinical associate professor of medicine and actually also program director of our endocrinology fellowship. And we've been talking so much about diabetes. I'm so excited to hear, her take on diabetes and fatty liver and how these things run together. So I'm going to turn it over to her. Thank you.
Great, thanks for having me. Thank you for that warm welcome. I'm going to try to share my screen. You guys can see that? We're good?
Great, looks good.
Okay, great. So, so as Dr. Halegwa said, I'm Monica Schrodkar from Jefferson Endocrinology, and it's an absolute pleasure to be here this morning. I think patient education is really one of my favorite things. So getting to speak to patients and motivating them is great. So today I'm going to briefly, we'll look at the relationship between diabetes and the liver. We'll talk about screening options, things that you should be asking your providers that are managing your diabetes. We'll quickly go through some medications that are beneficial in liver disease. And then also at the end, I'd like to just highlight a few questions that you really should be talking to your providers about, because a lot of this is sort of new and developing, and visits get really busy. So I think it's good when we're all on the same page and patients are knowledgeable about the types of questions that they should be asking. I have no disclosures or conflicts, so any of the medications that you hear me talk about is really just either through my own personal experience and evidence-based medicine and guidelines. And our American Association of Clinical Endocrinology just put out a new set of guidelines in May, focusing specifically on type 2 diabetes and fatty liver disease. So I always like to start off with a patient case and something that probably many of you can relate to. A 60-year-old female, history of type 2 diabetes for about 10 years. She has high blood pressure and high cholesterol. She has obesity. Her BMI is 37. For her diabetes, she's on metformin, 1,000 milligrams twice a day, glipizide 5 milligrams twice a day. She takes insulin at nighttime. And she's on lisinopril for her blood pressure and Crestor for her cholesterol. And she takes Lasix as needed for some intermittent leg swelling. Just to look at her labs, her A1C is 7.9, so not at goal. We typically shoot for 6.5 to 7. Her liver tests are in the normal range, but probably like on the higher end. And you can see her platelets are a little bit on the low end. So she's here in her endocrinologist office or primary care office, seeing a provider, probably focusing on that A1C that needs to be better. But should this patient also be worried about her liver disease? So based on our conference today, clearly she should be. Just to give a little background, I know you've heard about NASH and its risk progression to fibrosis, which is what we all want to prevent. And diabetes is one of the strongest predictors of this progression. So you have fatty liver, where you have excess sugar that's deposited in the liver. But as you've heard, if we don't sort of try to manage that and become more aware about that, it turns into NASH and then also fibrosis. So before we get into a little bit more on the medical treatment, I just want to talk to you about the bidirectional relationship. So diabetes in itself is a risk factor because we know it promotes fat deposition, which then leads to fatty liver and inflammation and cirrhosis. But also just having fatty liver and not having diabetes makes you predisposed to diabetes. And that's because of the insulin resistance environment that is created. So I'm going to talk a little bit about that because that's sort of been a buzzword lately. I know we've had some patients come in specifically asking about insulin resistance and medications that help with that. So what happens? We eat a meal, glucose is in our blood. The goal of glucose is to get into the cells and be used for energy. So whether it's your muscles, your brain, glucose needs to help those cells function. And insulin is the key molecule that helps glucose get into the cells. So you see in this diagram, insulin has a little key, there's a little door, it opens the door, glucose goes into the cell and it gets utilized as it should be. But with insulin resistance, the glucose can't get into the cell where it needs to be. The insulin no longer has that key, can't open the door, it's just not working as well. And a lot of times this is because of excess sort of fat in those tissues. And then the glucose just hangs out either in your blood, which then causes diabetes, or it gets stored in other tissues and it's turned into fat. So this entire environment is not just going to predispose you to diabetes, but it also creates this area of inflammation and all these things that then lead to metabolic syndrome, heart disease, fatty liver, and high cholesterol. So just wanted to touch upon that, and that'll become important when we talk about some of the medications later. So this is important too, and something that was shocking to me as I was preparing for this, that the rates of fatty liver and diabetics is extremely high. So about 70% of type 2 diabetics have fatty liver, and 15% of them have NASH. And what's worrisome is less than 5% are actually even aware of this. So it's really a conversation we need to start having as patients and as providers. And so what are we going to do about this? Screening, we have to start talking about it. We have to start looking for it. We have to identify who's at high risk. And as you've heard, this is really to prevent further progression of fatty liver into NASH and cirrhosis, and then hepatocellular carcinoma. And so you can see here, it's just sort of details normal liver, and then once you get into this fatty liver, and then the inflammation, and then cirrhosis. So let's catch this early and prevent that progression. So going back to our patient, should she be concerned about her liver disease? Absolutely, right? She's at high risk, just the fact she has diabetes. She already has these other metabolic parameters. So we really need to start talking about it. So from the endocrinologist standpoint, what do our guidelines say in terms of who should we be screening for liver disease? Or the American Diabetes Association guidelines recommend screening all diabetics and pre-diabetics that have increased liver function tests. So our patient might not have fallen into that category, but the newer guidelines that just came out in May 2022 suggest that we should be screening these patients even if they have normal liver functions and liver function tests. And I believe that the ADA, when they come out with the standards of treatment every January, will probably update their statement as well. And the key is here just that we know up to 50% of our diabetics have fatty liver, even with a normal liver function test. So once again, just highlighting that we need to really communicate this. And who else, and who is at risk? So as I said, obviously we know diabetics, but it's also the pre-diabetics. So if you're, A1C is 5.7 to 6.5, and your fasting glucose is not that bad, and maybe you're seeing your provider, your primary care provider, and they're keeping an eye on things, and you're doing a trial of diet and exercise, that's all very good. But please know that, you are also at risk and fall into that category of risk. And a lot of that is probably from that inflammation, insulin resistance type of environment. And then also, it's not just our diabetics that are not under great control. So even if you're a diabetic and you're on medication and your blood sugars are at goal and your A1C is at goal, you're still going to be at risk for fatty liver. So once again, just have that discussion. And so what can our general internists and providers, endocrinologists do? And you heard a little bit about this test before called the FIB4. And this is a simple test that can be done in the office based on the blood work you already have, most likely in your chart. It's non-invasive, and it's just a screening test. Put in the numbers, see where you fall in that risk assessment algorithm. And once again, it just highlights the need to kind of address the issue. And this just goes through the algorithm. So if you're a low risk and you plug in the numbers based on your age, your AST and your ALT, which are liver function tests, and your platelet count, it'll show you that you may be low risk. And in that case, that's great. And you could probably repeat it once a year or once every few years. If, however, you're in that intermediate risk or high risk, at that point, I personally would probably refer you to our hepatologist group and have them sort out what would be the best next imaging test, because I'm just not as comfortable in those areas. But the key is just having this test done once a year. I know that we are planning to put it in our EPIC link. So along with the patients we see that have their cardiovascular risk profile done, hopefully this will automatically be done and really highlight the need to look at this topic. So once again, going back to our patient, we plugged in her numbers and she turned out to be intermediate risk. So then she was sent over to hepatology to figure out what would be the best option for her imaging. But we still needed to talk about her diabetes and what would be the best treatment options for her. And you heard a little bit about the lifestyle modifications and diet and exercise, which I thought was really great. And some of the key points there is really the type of diet, but also we tend to like to tailor it to your personal preference. We know the importance of weight loss. What I really thought was interesting was that exercise was beneficial in fatty liver, even without weight loss. So going back to that insulin resistance, exercise itself will get glucose where it needs to be and helps lower insulin resistance and all that inflammation. So although we want to see weight loss and we know weight loss helps in fatty liver, any type of exercise is still going to help as well for both diabetes and fatty liver. And so before we go on to the medications I like to use, I just like to show this slide because I think it highlights that there's so many different organ systems that lead to hyperglycemia. It's not just that your pancreas doesn't work anymore. Your liver contributes to hyperglycemia. Your gut hormones contribute to hyperglycemia. Your kidneys contribute to hyperglycemia. And I think this is important because when we try to pick medications, oftentimes patients will say to me, well, if you're adding a medication, can I stop a medication? And so I try to go back to this diagram and say, we're trying to target various different organ systems in an additive way that will give you not only the best diabetes control, but also give you the benefits that some of these other medications offer. So what are some of the medications that we know have proven benefits in type 2 diabetes and biopsy proven NASH? And this is important because NASH in itself doesn't have any medications approved that I'm aware of. And so really we just rely on these diabetic agents. And the two agents that have been proven have been shown to improve disease progression are pioglitazone, which is Actos, and the GLP-1 receptor agonist. And the two agents in that group were Victoza and Ozempic. Now, these are in the studies, so there are medications that were used in higher doses, but once again, like I said, they were proven to reverse NASH on biopsy. So pioglitazone is probably one of the older diabetes medications. It's not commonly used. It's like our third or fourth line agent. So it's probably why many of you have not heard of it and may not even be on it. And it works to improve insulin resistance. It works on a specific receptor that really helps move glucose where it needs to be. It does specifically work on the fatty tissues. It's great because it doesn't cause any hypoglycemia. You can really add it on to any other diabetic agent that you're on. And as I mentioned, it has biopsy proven benefits for NASH at a higher dose, but experts will tell you you could probably use the lower doses, which we tend to do. We rarely use the highest doses, and you'll still have some benefit at the lower doses. So why does it get such a bad rap and it's not commonly used? A lot of it has to do with weight gain, and you will get some fluid retention with Actos, not as much at the lower dose. And this is the main reason a lot of people shy away from using it because of that weight gain. As you always hear that, your providers are trying to encourage you to lose weight. So why would they put you on a medication that makes you gain weight? Especially if you have underlying heart failure or you have end-stage renal disease where your fluid balance is very important. This is probably not the medication for you. Some of the other side effects or sort of negative press that Actos receives is fracture risk. So the data is conflicting at times, but we do know that if you're a female that has pretty severe osteoporosis, you're a high risk for fractures, this probably is not the medication for you. And also bladder cancer, once again, conflicting data on the risks of bladder cancer that may develop with the use of Actos at the highest dose, 45 milligrams. So we tend not to use in anyone that has a history of bladder cancer or obviously has active bladder cancer. So those are some of the side effects that prevent its use in the sort of day-to-day setting. And the other medication I want to talk about are the GLP-1 receptor agonists. These are sort of the newer agents over the past 10 years. I'm sure many of you have heard of them. There are several different companies that make them. They are all injectables, except for the last one, the semaglutide, which is oral Rybelsus. And you can see they work on many different organ systems when we're trying to treat diabetes. So they work on the liver specifically to help decrease glucose protection. They're gut hormones, so they slow down your digestion to help you lose weight. They also work to just improve insulin sensitivity. And they're a great class of drugs. The ones that were looked at in the study were Victoza, which is the once daily injection, which did improve liver histology. And then the Ozempic, which is a once a week, which also improved liver histology. Once again, at a different dose that we typically use in clinical practice, but experts believe that, all of these agents are worthwhile using in underlying fatty liver. So what are some of the advantages of the GLP-1 receptor agonists? A1C lowering is pretty impressive. You'll get about a 0.5 to 1% A1C lowering. You also get weight loss due to some of those side effects in your gut, and then you have NASH improvement, and you also have cardiovascular benefit. So it's a great agent to use. Some of the downside and why some people are unable to tolerate it is some nausea and vomiting. A little bit of nausea in the beginning is okay. I often tell my patients that just means the medication's working. It will get better with time. If you have vomiting once or twice when you're initiating it, it's not a reason to stop it. But if you have persistent vomiting and you can't tolerate it, we do recommend stopping, and we don't want anybody to become dehydrated and end up in the hospital because of the medication. It does slow your gastric emptying, makes you feel fuller, so you end up eating less, which is a benefit for weight loss, obviously. But if you have severe diabetes or gastroparesis, then this is not the agent for you. Pancreatitis is a very rare risk of these medications, but it is something we tell all of our patients about. So if you have severe left upper quadrant pain, you need to stop the medication right away and let us know. And then medullary thyroid carcinoma, once again, very rare side effect. This was shown in the studies in rats, and there's some C-cell hyperplasia. But I like to highlight this because this is not true with papillary thyroid carcinoma, which is the most common thyroid cancer that we see. Medullary is not very common at all. It tends to run in families. So you probably would know if that is a risk factor in your family. And then the other downside is cost. There are no generics for these medications, so they can be expensive. They're not always covered. And then it is an injection, and patients don't always like to inject themselves, but I try to convince them it's once a week, and we can all do something once a week that's beneficial for our health. And so what about these other medications that didn't make the list for having biopsy-proven benefits? Many of you may be on these medications, and they're all great agents, and they're all used for targeting various aspects of diabetes. We don't always have the best information in terms of do they improve NASH. So you can see insulin, DPP-4 inhibitors, metformin, SGLT2 inhibitors, and sulfonylurea. So I'll just go through these really quickly. So the SGLT2 inhibitors, Farxiga, Jardiance, and Vocana, I'm sure many of you heard of those. They work specifically on your kidneys. They're great for A1C lowering and weight loss. And essentially, you're going to urinate out your glucose, and with that, you lose calories, and that's how you lose weight. And the weight loss in itself helps with the fatty liver. But I do not believe there are any current studies that have shown on biopsy that it has NASH. It helps with NASH, decreased NASH progression. But I do believe they're underway. And these are great group of medications. They also offer cardiovascular benefits and renal benefits. They have no hypoglycemia. The downside is some dehydration because you are urinating a little bit more in the beginning. So we tell our patients to stay hydrated. And if you have a frequent history of UTI or yeast infections, this can sometimes exacerbate it. So those are some of the reasons we may not have you on these medications. Metformin, I'm sure many of you are very familiar with metformin. It's been around for quite some time. It's a great medication. It lowers the glucose output from your liver, but it actually doesn't have any significant benefit on NASH or fatty liver. But it does help with insulin resistance. It's generic, so it's affordable. It works. It's been around for a long time. And so it's one of the drugs that you absolutely should stay on if you need to be on for your diabetes. DPP-4 inhibitors, these are, Januvia, Tradjenta, Onglyza. They're typically used for mild hyperglycemia. They're easy to use. It's a pill. It's once a day. They're fairly well tolerated. But once again, no real specific liver benefit. Weight loss is neutral, so it's not really going to do much to help get a few pounds off. And the older agents, the sulfonylureas, once again, something, it's a common drug that many of our patients are on, generic, It's a pill, it's once a day. These are good when you're initially diagnosed with diabetes, but once you've had diabetes for a long time, they really just, their efficacy wanes, so they're not that useful. And then their biggest risk is hypoglycemia because they stimulate the pancreas to release insulin. And then insulin also, in certain situations with severe hyperglycemia, or your level of hyperglycemia, I should say, insulin is the only medication that may work. And there's no specific liver benefits, but clearly you need it for your hyperglycemia. Obviously, the downside to insulin is it's an injection, can be multiple injections, costs can be an issue, and then there's always that risk of hypoglycemia. So all those medications, your providers are probably using a combination of those agents to not only improve your diabetes control, but the key is to make sure we talk about agents that can also help with the liver disease. And so back to our patient again, we see her lab, she has her intermediate FIB-4 score. What would be the next step in terms of what agent should I add that will not only help her A1C, but also help with this progression of her liver disease. So in this situation, I would choose Ozempic. It's a once a week agent, and the goal would be to improve her A1C, to help initiate that weight loss, prevent the progression of NASH, since we know that these are biopsy proven medications, and hopefully help just her overall metabolic status and give her some cardiovascular protection as well. But unfortunately, a lot of times these are not covered, or they're not affordable. So in those situations, I would say try an alternate class of GLP-1. Your insurance company may cover a different GLP-1, and even if it doesn't have the biopsy proven results behind it, it will still most likely give you some significant benefit when it comes to the diabetes and the liver. If the injections are not covered or you're unable to tolerate it, my next option would be to move to an SGLT inhibitor because they also induce weight loss, will help lower that A1C and give cardiovascular and renal protection. And then Actos for her would be lowest on my list just because she already has some edema, and I would be afraid that with insulin and Actos, sometimes you can have even more water retention. So it wouldn't be completely off the table. I may consider adding just a low dose of 15 milligrams, see how she does, especially if we're able to have her on a GLP-1 or an SGLT2, which will help with fluid retention and some weight loss. So it's a little bit of a balancing act, I guess, and you try your best, but I think it's important to talk about these agents and the benefits that they can provide. So in conclusion, if you have diabetes or prediabetes, you are definitely at high risk of fatty liver, which can progress. And so I would advise you to start the conversation with your providers. If you're seeing your endocrinologist, your primary care provider, or a physician extender, it should be more than just focusing on that A1C. I would suggest talking to them about, should I be screened for liver disease? And the thought might occur that, well, your liver tests are normal, I think you're fine. But I think, there's definitely some room to continue that conversation and highlight that even normal liver tests can still mean that you're at high risk. You can ask them, have you heard of the FIB-4 score? Or is this something that we can just plug in some of my lab values and see what my risk status is? And then also see if there's some imaging in the system. Many patients have CAT scans for other medical conditions, and oftentimes there'll be a comment on there about fatty liver that may be overlooked because the CAT scan was done, maybe for a kidney stone or something. So it's something good to think about and discuss with your providers. And then, am I on the best medications for my diabetes and my liver health? And just sort of, continue that discussion to prevent and reverse this disease from progression. So that is all I have. And this guy, whether he has type 2 diabetes or fatty liver, I don't know. I have my suspicions, but I thought that it would be important to give him a shout out today because we love our Phillies and we're so excited for them. So that's all I have.
Thank you, Dr. Shredkar. I think this was excellent. And I know that at Einstein, collaboration with endocrinology is definitely key. And we're both learning from each other's specialties at this time. So I think this great communication between our specialties and really learning from the hepatology standpoint, learning about diabetes medications and from the, the endocrinology side, learning about all the details of our day-to-day practice is really excellent. So thank you.
Great. You're very welcome.
So we are now going to announce 2 more winners in our spinning wheel for the packages and the baskets that we have. So another name is coming on. So let's click it and spin. And the winner is coming. So another basket is for Gwendolyn S. And I hope you enjoy your basket. We'll announce a second winner. You know, there's going to be some excellent prizes in those baskets. You'll see sweatshirts and bags and goodie bags. So hopefully you have an interesting. And that's Debbie. So thank you both for participating in our program. And again, you'll hear from our coordinators to make sure those baskets get to you. So that's all for now. We are taking a 10-minute break. We changed it so that we can keep track a little bit with our time. But during this break, we're not going to stay idle sitting in our desks. We're all going to get up and do some movement break with Christina Unger. She's been a GI yoga instructor. She's worked with our programs at Einstein in the past. So enjoy this, take your time, really try to get up from that chair and move around so that we can all get our liver health. And you'll see some virtual exhibits in the afterwards. All right, and here we go.
Okay, well, we're all back from break. Hopefully everybody got a little bit stretched out there.
I would like to present Dr. Banca if he's ready. And thank you for accommodating for the change in schedule time. Dr. Banca is the director of our cardiac catheterization unit here at Einstein. He's part of our multidisciplinary team that helps with cardiovascular evaluation of patients going for transplant. And he really is a wonderful colleague that we use all the time to help assist with our patients. And so we're going to talk a little bit about fatty liver and cardiovascular risk, which is one of the most important things we would talk about today. Thank you, Dr. Banca. Welcome.
Good morning. Thanks. Can you hear me okay?
Yeah, perfectly.
All right. Well, thank you for the introduction. Thanks to the hosts and Dr. Lagarde for having me today. I get to talk to you about my favorite organ, but of course, we're talking about fatty liver disease. So we're going to talk about the relationship between fatty liver disease and cardiovascular disease. Both are very important organs, and they have an important relationship. So let me start by just introducing a little bit about myself so you know who you're speaking with today. This is my lovely family and my favorite, maybe the favorite family member. I'm a big fan of the Eagles and the Phillies, so this is a very exciting weekend for us. And so looking forward to watching them later on today. And this is some of the stuff that I like to do in the cath lab. It involves lots of wires and balloons and things like that. But really what I think is important is preventing us from ever getting to the point where somebody would need a kind of complex heart procedure to be done. That's really my passion, is trying to do preventative medicine and prevent major heart disease problems. So talking about cardiovascular disease and fatty liver disease, it's really not surprising that there's a lot of overlap between these conditions, and because they share increased risk factors. And we'll go into that, and you've heard a lot about some of those things earlier today. There is evidence that fatty liver disease increases the risk of high blood pressure, coronary artery disease, cardiomyopathy, which is abnormal heart muscle or weakness of the heart muscle, and heart arrhythmias. And many of you know heart disease is the leading cause of death in patients with fatty liver disease. So let's just talk about heart disease in general. Heart disease is the leading cause of death in all people in the United States, in men, women, and most racial and ethnic groups in the United States. And there's our heat map of heart disease deaths in the country, and you can see it's everywhere. It's predominantly in the Midwest and the South is the leading areas, but it's all over. And every 34 seconds, someone in the United States, unfortunately, dies from cardiovascular disease. This is about 1 in 5 deaths that occur in 2020. And coronary artery disease specifically is a form of heart disease, and that is the most common type. And about 382,000 people died of coronary artery disease in 2020. And that accounts for about 20 million adults. 20 million adults age 20 and older have coronary artery disease. So it's very, very common. Most people do have some, but it is mostly asymptomatic. So this is why they give it these names like silent killer and scary things like that. But we're going to talk about how we can lower our risks as we go forward. Coronary disease is really an additive process. We have the risk factors, which we kind of call the big five, which would be high cholesterol, diabetes, high blood pressure, obesity, and smoking. If you have some of these risk factors, about 90% of heart attacks, strokes, or cardiovascular events occur in people that have at least one of these risk factors. So they really are powerful risk factors. And if you start adding those risk factors to some other ones, such as what they studied in this chart here, which is from the INTER-HEART study, which was published in the Lancet Journal in 2004. They looked at not only the big five, but also some other additional risk factors like stress, alcohol use, inactivity, which is a really big one, lack of fruits and vegetables in your diet. If you start adding up all those risk factors plus the big five, you see all the way on the right there, your risk of having a heart attack is 333 times those who don't have those risk factors. So as you start adding risk factors, they really do contribute to increased events. So what about cardiac disease and liver disease? Just put a little cartoon here to keep you guys interested. How does cardiac disease and liver disease interact, and what are the contributions of each? Well, if you look at patients that have advanced liver disease, we're talking not about fatty liver disease, but really advanced kind of cirrhosis and disease. We used to think that because they have low blood pressure, they actually have low cholesterol because the liver doesn't synthesize the cholesterol proteins, that they have higher levels of circulating estrogen, that they would have a low risk of having coronary artery disease. But in fact, if you look at patients that are looking for liver transplant who have really advanced disease, about 30 to 40% of them have significant coronary artery disease. So it's a bit of a paradigm. Even though the blood pressure is low, the cholesterol is low, those risks haven't gone away. So there's something more to the coronary disease. And talking about liver transplant candidates, again, patients who have really advanced disease, about 1 in 4 of them have moderate asymptomatic disease, meaning they don't feel any symptoms from it. And it's not blocking blood vessels to the point where they get symptoms, but there's still blockage present in their heart arteries. The greatest risk of having that problem is those that have greater than 2 traditional risk factors. So the traditional risk factors are older age, a family history of heart disease, high blood pressure, high cholesterol, and smoking. And we're seeing more and more of this coronary disease in patients who are being thought about as having for liver transplant, because we're now considering patients who are older and for patients that have more fatty liver disease as the reason for their advanced liver disease. Now, fatty liver disease and coronary artery disease or cardiovascular risk is a very complex interplay of various factors. There's the diabetes, there's obesity, of course, high cholesterol, high blood pressure. All of this goes around an inflammatory process. There's inflammation in the liver, and this can cause problems in other organs, essentially. But we do know that the more fibrosis that's present on a liver biopsy, this seems to be related to a higher risk of cardiovascular disease. And in fact, it is thought that fatty liver disease might be an independent predictor of cardiovascular disease. It's not well proven yet, but it's believed to be the case. And we try to link these two conditions together. You have, fat in the visceral tissues in the abdomen and in the liver, and you have altered gut bacteria, and this leads to insulin resistance, as you heard before, and some increased risk of what we call endothelial dysfunction, which is an abnormal reactivity of the lining of the blood vessels. So, sorry, I have to flip back and forth here. This can lead to increased coronary artery disease. There's changes in the cholesterol that we have in our blood, and there may be also changes in the plaques in the arteries that make them more unstable and increase the risk of heart attacks and also the risk of blood clots. Overall, there's also a direct effect of this inflammation on the muscle of the heart itself, which can increase the thickness of the heart muscle, which we call cardiac mass, and another condition called diastolic dysfunction, which is an abnormal way that the heart relaxes. It pumps normally, but it doesn't stretch as it ought to normally. So a lot of subtle different effects on the heart, and I'll go into that a little bit here. So fatty liver disease and coronary artery disease are related. Here I have a picture of a narrowed heart artery. You can see in panel A, this is on a CAT scan, and in panel B, this is on a heart catheterization where we inject X-ray dye into the heart artery, but pretty similar pictures here. But fatty liver disease is associated with what we call increased carotid medial thickness, which is thickness of one of the walls of the blood vessels, and also coronary artery calcium. These are both just markers of buildup of cholesterol plaques in arteries. But they also notice that patients who have fatty liver disease have higher risk plaques, meaning these plaques, like I mentioned before, are a little bit more unstable and more inflamed. And when patients with fatty liver disease do have heart attacks, unfortunately, they don't do as well. They have a worse outcome. There's also a relationship between fatty liver disease and heart valves. So these are pictures of heart valves. That's the aortic valve, which is the top valve of the heart, which has 3 little leaflets on it and opens up normally with every heartbeat. But you can get increased calcium on the heart valve, on the aortic valve, and the mitral valve, the lower valve in the heart. And there's also, as I mentioned, diastolic dysfunction, which is abnormal relaxation of the heart muscle. And finally, there's an increased risk of arrhythmias, which is abnormal heart rhythms, such as atrial fibrillation, which many of you have heard of. So that's a lot of bad news. Is there any good news? That's a lot of serious conditions that can be related to liver disease. So there is good news, and that's why we're here today. Most importantly is education and learning about your risks and trying to reduce your risks, and there's a lot that we can do in that way. Cardiovascular disease prevention for patients with liver disease is really the same advice that I give to all of our heart patients or anyone who has risk factors for heart disease. And this is primary prevention, meaning just general heart healthy behaviors. And you heard a lot, had a great talk about diet earlier, and I learned a lot from that as well. First of all, the most important thing is weight loss, which is easier said than done. We all know that. It involves changing our behaviors and the way that we live our lives in a lot of different ways. And that's always a challenge for us with humans with our set behaviors. But the diet that we recommend for the heart healthy diet is similar to the diet that was discussed earlier for reducing your fatty liver, and that's a Mediterranean style diet. And what that constitutes is predominantly fruit and vegetable based diet, whole grains, a low fat dairy in your diet, mostly fish rather than red meats, and using legumes, non-tropical vegetable oils, and nuts. Exercise is, I can't express how important exercise is. And we have goals of 2.5 hours a week of a moderate intensity exercise, or if you're into high intensity exercise, 75 minutes a week. but really, as we always say, something is better than nothing, and you're lapping everybody on the couch. So if for you 10 minutes a day is what's achievable, that's a great place to start. And people who do even short bursts of exercise per day do much better than people who don't do any exercise at all. So don't feel discouraged if you're not a big exerciser. Starting with basic walking or 10 minutes a day of walking is great, and it does help. And there's plenty of studies to reinforce that. So also importantly is to talk with your providers, your healthcare providers, about what your personal risk of heart disease is. And we have different tools that can be used to help to figure that out. One is called the Framingham Risk Score, and one is called the ASCVD score. And using those risk factors can help tailor your medical treatments to reduce your risk. And of course, be working with your physicians to help lower your cholesterol, your blood sugar, your high blood pressure, and most importantly, non-smoking. So there is good news. Well, this is the ASCVD risk score, sorry, the Framingham risk score that I put on the side here. We basically plug in your age, gender, cholesterol results, and blood pressure as a couple of other risk factors. And it gives you a calculation of your 10-year risk of having a heart or vascular related incident or a heart attack or a stroke. And knowing that information can be very helpful, and it can help us figure out what is the best way to treat you medically and otherwise. And so if you look at a patient, 293 patients were studied who had NASH, and they went through lifestyle changes. They did a low calorie diet, and they did 200 minutes a week of walking for a year. And 25% of them had resolution of their fatty liver disease and regression of fibrosis at 19% of them. So that's a great improvement. And as you've heard earlier today, the improvement is highest in those who managed to achieve significant weight loss. What about statin medications? This is really a question I get asked a lot, and I work with our hepatologists to help patients get on statin medications when they are indicated. There's a lot of data now, 20 years or more data, that statin medications lower your risk of cardiovascular disease, especially if that 10-year risk score is greater than 10%. Those are the patients that get the most benefit. Statins, if you know, are things like Lipitor, atorvastatin, or Crestor, or Simvastatin, have a lot of different names. All diabetics are indicated by most guidelines to be on a moderate intensity statin medication. Doesn't really matter what the absolute cholesterol number is. There's a lot of anti-inflammatory benefits to being on a statin medication. And I find that these statin medications are very underutilized in patients with fatty liver disease because people are worried about the statin effect on the liver. And also many people find they are concerned about muscle symptoms of muscle soreness. But if you look at the literature, it's an extremely rare cause of liver failure, statin medications. They can increase your liver enzyme numbers, but this does not really lead to increased liver injury or liver failure. So in patients that are recommended for a statin, the risk of liver toxicity is very low, and the benefits of towards your heart health are very high. So it tips heavily in the favor of being on a statin medication. There's even some small studies that show that NASH can be improved by being on a statin medication. One study looked at the statin medications in Greece. This is called the Greek atorvastatin and coronary artery disease study, called the Greece study. And they looked at 1,600 patients who had abnormal liver disease, liver tests, and they thought they had fatty liver disease. They treated them with atorvastatin, which is also known as Lipitor, for 3 years. And they were pretty low dose on the Lipitor, average about 24 milligrams a day. And those patients had improved liver tests and lower cardiovascular events over the 3 years than people who were not on the statin. So it's important to consider this. The major guidelines have not specifically addressed whether fatty liver disease patients should be on statins just for fatty liver disease. But if you have risk factors such as diabetes or your 10-year risk score of heart attacks is high, it's certainly important to think about it. And in the future, it may be a population where we think about it the same way we do about diabetics. Many patients ask us about aspirin. Aspirin also has great benefits in patients with high risk for cardiovascular disease. But lately, there's been some information that patients who are at lower risk and who are older than 60 should not be on an aspirin. And that's because there is a consideration of bleeding. Aspirin does thin the blood and can cause increased bleeding risk, especially as we get older. So that decision needs to be individualized. Everybody should not just be taking aspirin over the counter for heart disease prevention. It really has to be an individual decision that's made with your healthcare providers. There is some information that aspirin might inhibit fatty liver disease, but this has not really been well studied. And there's very low risk of liver injury with aspirin itself. You heard from Dr. Schroeder about diabetes medication. There are a few that are pretty beneficial in preventing heart disease. Pioglitazone showed to reduce mortality, stroke, heart attack in patients with diabetes. There was a trial called the PROACTIVE trial, which showed a 28% decrease in heart attacks and a 47% decrease in stroke. And those are pretty big numbers. But it does carry increased risk in patients who have heart failure, congestive heart failure. So you need to talk about your physicians or your providers about that. Liraglutide is another medication for diabetes that improves cholesterol and lowers blood pressure as well, and shows a reduced cardiac events. Some of the newer medications, which are really very popular right now in our field, especially with patients with kidney disease and heart disease, Farxiga and Jardiance are called SGLT2 inhibitors, and they are known to improve cardiac risk in diabetics, but not really well studied directly with fatty liver disease patients. Many patients ask us about vitamin E. This does not have any direct cardiovascular benefits, so would not take it for that purpose. And bariatric surgery, which I know you're going to hear about soon, it involves significant weight loss, and patients who achieve that have decreased blood pressure, cholesterol, and cardiac risk through that weight loss. So I will conclude here by summarizing and saying that fatty liver disease and cardiovascular disease both share many risk factors. Fatty liver disease may independently increase the risk of heart disease, cardiomyopathy, which is abnormal heart muscle, and arrhythmias. But these heart risks are modifiable. We can change them through diet, exercise, and weight loss, and aggressively controlling the diabetes, the high blood pressure, and the cholesterol. But every patient's risk assessment should be done with your provider. You should go through that Framingham score, ASCVD score, and then decide if an aspirin or a statin medication is something that you should be taking. But if it is, these medications can lower your risk if it's higher. So this is why the real reasons that the dinosaurs became extinct, because of their smoking. But thank you very much for allowing me to talk today, and I'll turn it back over.
Great. Thank you, Dr. Franca, again for your expertise and for really highlighting the importance of cardiovascular risk prevention in patients, not only with fatty liver, but in general with metabolic syndrome. So thank you.
And I'm excited to get back into our presentations and to introduce one of my esteemed surgical colleagues, Dr. Taylor Tartarian. She is an assistant professor of surgery at Thomas Jefferson University Hospital. She's also deputy co-chair for clinical research in the Department of Surgery and associate director of the Advanced Gastrointestinal Surgery Fellowship, and one of our excellent bariatric surgeons. And she's going to tell us about the role of bariatric surgery in the treatment of NASH.
Thank you
very much for the invitation to speak today. I mean, these have been some fantastic talks and I've been learning a lot as well. So I'm going to be providing a little bit of a different perspective and talk about the role of bariatric surgery in the treatment of non-alcoholic fatty liver disease and NASH. This is something that some of you may already be familiar with, or it's a completely new topic, so I'll just give a general overview. I have no disclosures relevant to this talk, but my goals for today are to help everybody understand the association between NASH and obesity, to review the effects of weight loss on NASH. I know we've talked about this a little bit. And then specifically when it comes to bariatric and metabolic surgery, discuss some of the surgical options that we have, the procedure types and the associated risks and the outcomes with regard to overall health and liver disease. So non-alcoholic fatty liver disease, as we've seen, has really paralleled the rise in obesity that we've seen. There's a really strong connection with the epidemic of obesity, as well as an association with what we call metabolic syndrome. Metabolic syndrome being, the overall presence of high blood pressure, cholesterol, diabetes, all of the other medical conditions that can come along with obesity, as well as insulin resistance and diabetes, as we just heard about. To the point where a recent consensus actually had recommended renaming non-alcoholic fatty liver disease to metabolic fatty liver disease, because they're all kind of so intertwined with one another. But for today's purposes, it's non-alcoholic fatty liver disease and NASH. So the prevalence of NASH and fatty liver disease both really increase as BMI increases. So if you look at this image on the left-hand side, each row kind of represents a different BMI or weight range. And as the BMI increases, the percentage of patients that have fatty liver disease increases and that have NASH increases. So at a BMI of around 40, a patient is about 100 pounds overweight, over their ideal body weight for their height. And at that point, at least 60% of patients with that degree of obesity have some component of non-alcoholic fatty liver disease, and up to 10 or 11% experience NASH. When you go up to a BMI of 50, that goes up to about 20% with NASH. So obesity alone has been shown to be a risk factor, an independent risk factor for NASH, at least a twofold increase. And then when you add on metabolic syndrome, so you add on things like diabetes, high blood pressure, cholesterol, that risk goes up threefold. Now with obesity in the United States, this graph is showing really the prevalence that we've seen that has been really increasing since the 1960s. The green lines represent obesity and the orange lines represent severe obesity in both men and women. And we can see that since the 1960s, there's been a steady rise in both. And then as of 2018, when this graph ends, an estimated 42% of adults had obesity, 9% with severe obesity. And this graph isn't showing the additional 30% of Americans who are considered overweight, so over a BMI of 25. So by 2030, it's expected that the prevalence of adult obesity will increase to 48%, which is concerning because, as we've seen, liver disease and obesity do tend to go hand in hand. And this is another way of kind of showing that as the colors change, it's showing that the prevalence of obesity is rising. So this was in the 90s, then in the 2000s, in the 2010s, 2020s, and you can see the prevalence of obesity is getting more and more. And then we see this is what's predicted in 2030. So how do we define obesity? I've referenced this term BMI, but the BMI is really, it's a measure of your weight in kilograms over your height in meters squared. So BMI under 20, in the 20 to 25 range is considered that healthy range. Over 25, it's considered overweight. 30, you get into obesity. And then 35 to 40 is really where bariatric surgery starts to come in. I'm going to talk about that in a little bit. But as I mentioned earlier, a BMI of 40 is approximately 100 pounds over the ideal body weight for your height. And there's calculators to help you determine what is ideal body weight. This was a simple chart I actually took off of Wikipedia. So if you look at your height on the right-hand side in feet and inches, and then move over towards the left and correlate that with your weight, you can kind of get a sense of what range you personally are in with your height and your weight. And again, if you just Google BMI calculator, you'll be able to find your current BMI basically by just inputting some simple numbers. So weight loss and NASH, we've already kind of talked about this, but the primary treatment, as was discussed, is really lifestyle modification, which means diet and exercise. And it has been proven that weight loss really does work well and leads to a resolution of NASH kind of in a dose-dependent fashion. So the more weight you lose, the better resolution that we see of that NASH. When you lose about 3 to 5% of your body weight, that can reduce the fatty liver disease, and over 7%, we really start to see resolution of that steatohepatitis. This was another study that showed that in almost 300 patients that had NASH and an average BMI around 31, so considered obesity, using lifestyle modification, about 4% of, the majority of patients were able to lose about 4% of their body weight, which allowed for a resolution in that NASH of about 25%. And when you lost over 10% of your body weight, they saw that up to 90% of these patients were having almost complete resolution of their NASH. Now, the catch, though, is that of these 300 patients, only about 10% of them were able to achieve that degree of weight loss. And like we've talked about, this is something that's incredibly difficult to do. Diet and exercise, very, very important, but to get the degree of weight loss that might be needed sometimes becomes difficult the higher your starting weight is, okay? And this is kind of something that we talk about in our bariatric surgery clinic. This is the obesity treatment pyramid. And at the foundation of everything is this, the belief in lifestyle modification. So the importance of diet and exercise, that's going to be, whether you go the surgical route or go with medication, these are factors that are going to need to, be modified. So at a BMI of around 25 is when we normally start recommending these lifestyle modifications. When your BMI gets closer to 30, you may have some options as far as additional medications go, which we had discussed earlier. And really a BMI of 35 to 40 is where surgery comes into play. So I'm going to get a little bit more into surgery, but I just want to offer a disclaimer that this is not yet frontline therapy specifically for NASH. We do need some randomized controlled trials to really be able to show that metabolic and bariatric surgery and compare it to medication and lifestyle changes alone to really show the effects. But it really should be considered for the treatment of underlying obesity and those other conditions with metabolic syndrome that I mentioned, with the goal of anticipated benefits for the liver disease itself. So you're treating the obesity, you're treating the other conditions, and you're treating NASH as well. So who qualifies for surgery? Really, most insurance companies follow a BMI of 40 or greater, you'll automatically qualify. Or if you have a BMI of 35 with another, what we call obesity-related comorbidity, so another medical condition, and I've listed a couple examples here: diabetes, high blood pressure, cholesterol, sleep apnea, and then fatty liver disease or NASH as well. The other catch is that we need to demonstrate that you've tried through lifestyle changes to lose weight and have not been able to do this successfully for long periods of time. So usually this is about a 6-month period of documenting, you made lifestyle changes, but we haven't been able to get you down to a healthy weight. So the different surgical types, I bring up gastric banding, commonly referred to as the band, because a lot of you have probably heard about this or know someone who's had this done. We put essentially a plastic band around the top part of the stomach. And what this does is it helps make the stomach above the band smaller. So you feel full a lot faster when that part of the stomach gets full, and that helps you eat less and lose calories and lose weight. But really this has fallen out of favor because the weight loss that we were seeing historically with this was not great. But really, and there was also a very, very high complication rate when it comes to the band slipping, eroding, or causing holes into the stomach, causing really bad heartburn and reflux. So this is not something that's performed in most practices nowadays. Really, the sleeve is the most common bariatric surgery procedure and what is commonly recommended for patients with NASH or even cirrhosis in certain cases. Essentially, we use a stapler to remove about 2/3 of the stomach. So the portion of the stomach that you see on the right-hand side, that gets completely removed out of the body, and the new stomach is about the size and shape of a banana. And this kind of works in 2 ways. First, with the smaller stomach, there's a smaller storage capacity for food, so you consume less calories, and then that leads to weight loss. But the second is by removing that larger or 2/3 part of the stomach, you decrease a hormone called ghrelin, and when you decrease ghrelin, that decreases your appetite. So together, the average weight loss that we see is a total body weight loss of about 30%. So if you come in weighing around 300 pounds, let's say, the weight loss expected after a sleeve gastrectomy is somewhere around 90 pounds or so. So it gets you closer down to 200. Okay. Now, the plus side of this procedure is that it is a relatively straightforward procedure. We're not doing any work with the small intestine. We're only working on the stomach. This is done laparoscopically or robotically through small incisions. We're not putting in a foreign body or that plastic band like we mentioned earlier, and it is a short procedure. It takes about an hour to an hour and a half. We do recommend lifelong vitamin supplementation, but after a sleeve gastrectomy, it's rare to have any major iron deficiencies and things of that nature. The downside is that it's not reversible. We cannot put that part of the stomach back. And newer data is showing that about 10 to 15% of patients are developing new onset heartburn or reflux after this. So if you're coming in with pretty bad heartburn or reflux to begin with, this might not be a great option. And that's really where the gastric bypass comes in, or the bypass. This is the second most common bariatric procedure, performed probably in about 40% of cases. And the difference here is that we're restricting the stomach size, but by also adding in the small intestine and hooking it up to that new stomach, you're causing malabsorption. So here on the right-hand side, you can see where the new stomach has been created and a piece of small intestine has been brought up and connected to it. So the food that you eat are these red arrows. It comes down into the new pouch, goes down into the small intestine. And then the green is the old stomach, and then where the bile juices and the pancreas juices and digestive enzymes all come down, meet up with the red arrows, and that's where you start absorbing those calories and nutrients. Since you're bypassing some of that intestine, the weight loss that we see is somewhere on the order of 35% of your body weight. So not a huge difference in weight loss compared to the sleeve, but as you start getting to the more extremes of BMI, so BMIs 50s, 60s, adding this component of malabsorption does help lead to additional weight loss. The plus side is we do tend to see better outcomes with reflux, as I mentioned, as well as with diabetes. I mentioned the weight loss. And then I'd say it's technically reversible. If for any reason that was needed, it is doable. It is a big operation, but something that we can technically do. With gastric bypass, though, the importance of lifelong vitamins is very, very important. Especially for things like iron, vitamin B, to make sure that there's no anemias or vitamin deficiencies. There are some additional risks that are different compared to the sleeve, and the two most common that we think about are marginal ulcers and internal hernias. So marginal ulcer is a stomach ulcer that forms at that new connection between that stomach and small intestine. It happens in about 5 to 8% of patients. Usually able to treat with an antacid medication. But the reason I mention this is if you've had a gastric bypass for life, no smoking and absolutely no ibuprofen, because those are two things that can cause these ulcers to form. And then an internal hernia is a fancy word for a bowel blockage, because we are rerouting some of those small intestines that can lead to a bowel blockage in about 1 to 2% of patients. And about half of those may need an operation to help fix that. Okay. So what are the benefits of the weight loss? I mean, we've talked about, we'll talk a little bit more about fatty liver disease, but we do see all these other medical conditions that do improve with weight loss. So sleep apnea is resolved in up to 98% of patients. Most patients are able to come off of their CPAP machines. High blood pressure, cholesterol is resolved in up to 70% of patients. And that's resolution. I'd say almost 90+% of patients are at least able to come down on the medications that they use less medication or lower doses. We see an impact on osteoarthritis, joint pain, knee pain. So these are all things that can improve with weight loss. And then when it comes to liver disease, both sleeve gastrectomy and gastric bypass have shown significant improvement in biopsy-proven liver disease. We've seen decreased rates of both steatosis, which is the fattiness, and the fibrosis as well. The ASMBS, which is the big governing society for bariatric surgery, recently put out a position statement, and they had looked at almost a dozen studies that had biopsy before and after bariatric surgery, and they saw that up to 87% of patients about a year and a half out from surgery had complete resolution of their NASH. That number was a little bit higher after gastric bypass, about 91% compared to 80% after the sleeve gastrectomy. And that's probably due to the additional weight loss that we see with the gastric bypass. And then the other important thing was that there were no cases of progression from fatty liver disease to NASH in these patients. Okay, this was another study that had come out. It was a retrospective study. So that means that the patients that had already had the surgery, they went back in time and looked at their outcomes in almost 3,000 patients with non-alcoholic fatty liver disease. And they compared those that had surgery to those that did not have surgery. And the patients that had surgery were a third less likely to progress on to cirrhosis. These patients also had improvement in the fatty liver disease and steatohepatitis, as I had mentioned. So really tremendous outcomes that we're seeing with this. And we can attribute it, I think, to a lot of the additional weight loss that's seen with surgery compared to some of the other treatment strategies that we've mentioned. But like I said, diet and exercise, lifestyle modification really is the foundation for everything. And we do tell our patients that if you don't keep up with that diet and exercise piece, surgery also will not work. It's really a tool to help with the weight loss. Now, a lot of you are probably thinking, but how safe is this? You know, you probably have heard of bariatric surgery before or know someone who's had surgery and maybe didn't have the best of outcomes. And historically, that was the case, unfortunately. So if we look at this graph, the blue bars represent the rise in bariatric surgery since the early 90s. So as of 2016, there was about 165,000 bariatric surgeries performed a year. Currently, we're well over 200,000 a year. The yellow line shows any complication that occurred after surgery, and the red line shows what we call the mortality rate, or patients that died after surgery within those 30 days. Okay. Really, the complication rates were really high in the early 90s, and I think that had to do with the way we were doing these surgeries. As you can see, the complication rate really started to come down in the early 2000s, and that's when we really started to use laparoscopic techniques. So minimally invasive surgery, smaller incisions, shorter operative times, and the complication rates have really, really come down since then. So some specifics. This is a chart of outcomes from all patients that had bariatric surgery nationwide in the year 2018, and it's comparing the sleeve gastrectomy and the gastric bypass. So when we think of complications, the most feared complication is something called a leak. So if any of those staple lines or intestinal connections don't heal well, that could make patients sick and they would need another procedure or procedures to fix that. Well, the risk of that is less than 1%, well under 1%. So about 0.3% for a sleeve and 0.6% for a bypass. The risk of bleeding is also exceedingly low, less than 1%. It's very, very rare to need any kind of blood transfusion from this. And the risk of complications is somewhere in the order of 2 to 4%. When we think of complications, I mean, that can even mean things like a urinary tract infection, or a pneumonia, or a prolonged hospital stay. So more than a day is what we think about when we think about bariatric surgery. And the risk of death is less than 0.1%, so less than 1 out of every 1,000 patients. Okay, and surgery time is also very, very low. So then where does this compare to some of the other procedures that we do? Theoretically, bariatric surgery is much safer than some of the more common operations like gallbladder removals, hip replacements, and heart bypass surgeries. So the risk of death after bariatric surgery, like I said, is about 1 out of every 1,000 patients. And after a routine gallbladder, it's about 5 out of every 1,000 patients. Now, some of that has to do with the fact that we do a ton of workup. You're seeing your cardiologist, you're seeing your pulmonologist, you're seeing your liver doctor. We make sure that everything is perfectly in order before you go on to have surgery to make sure it's as safe as possible. Okay. And then long-term surgery, we've shown that it can really help to reduce that mortality after surgery as well. So the risk of death we've shown is lower in patients with obesity that have had bariatric surgery compared to those that have not. And again, that really goes into showing that it's really helping to improve the overall health, reducing diabetes, reducing high blood pressure, reducing liver disease, and all of these kind of help to reverse the effects of the obesity on long-term health and mortality. So a couple final thoughts. Fatty liver disease and NASH, like I mentioned, is strongly associated with obesity, insulin resistance, metabolic syndrome, and type 2 diabetes. Weight loss is still prioritized as a first-line therapy, okay? But bariatric surgery has shown in observational studies, at least, that it does have a positive impact on liver, NASH resolution, and then reversal of that fibrosis. Okay. But really, randomized trials are needed before this can start to be established as a formal treatment for NASH. So my recommendation to you is that if this is something that you think may apply to you or something that you may be interested in, definitely talk to your gastroenterologist, your hepatologist, and some of your other doctors as well. And we can see if it's the right option for you. You can either call the number I've listed below, or this QR code will lead you to a webpage to make an appointment. And we have locations kind of at all of the Jefferson centers, so you can find a place that's close to home. All right, thank you. And I'd be happy to take any questions later on.
Yeah, thank you, Dr. Tartarian. That's great data to see. You know, weight loss is, we're talking a lot about it, but it's so hard to do and even harder to sustain. So it's great to see, you know, there are options that are available, especially if you have a lot of weight to loss, and the safety with bariatric surgery. Thank you. Well, thank you. So we'll definitely have some questions at our last session, but Dr. Lagarde and I are now going to talk a little bit more about treatment. And I'm just going to share my screen here. So, you know, we've been talking a little bit throughout the presentation. All of our speakers have mentioned some of the treatments, but we wanted to get a little bit more into it, and specifically talk about some treatments out there.
Yeah, great. Thank you. And again, thank you everybody for staying with us. We are on our last stretch, so hanging there, almost there. You know, I think one of the things that we really target and when we talk to our patients is, well, now, like I said, now you've identified you have fatty liver. You talked about your doctor as to where you are in the process of fibrosis or scar tissue. What can I do now? And the first thing that we have talked about, and it's really the reason we put this in a triangle or like mountain, is because we really want to see that changes in your lifestyle are really the tip of the iceberg. So they're part of the treatment strategy, but they're definitely not alone. And so what the things that we can control are weight, and that's why we focus so much with you in the clinic and with our dietitians and through our bariatric programs at each one of our institutions, is because we know that weight loss improves both the amount of inflammation in the liver as well as potentially decreases the amount of scar tissue. So we really have to focus on that. But also we know that cardiovascular risk is the #1 reason that patients with fatty liver die and have this major complication. And so that is one of our most important things that we have to address, together with managing their glucose and managing their diabetes. But then there are other treatment strategies that we hopefully in the next few years, with all the research that is on their way, we are going to be able to identify specific areas of directly related to the liver, where we can target both the amount of fat in the liver, the amount of inflammation, and hopefully break down some of that fibrosis or scar tissue in the liver. And that really is the goal that we're looking for in all these research strategies.
Yeah, and I'll just echo that, you know, as we talked about that, you know, people who already have damage to the liver, you know, we may need some of these additional treatments when lifestyle changes may not be enough. They're definitely still the cornerstone of treatment, but there's additional treatments that hopefully we could offer to improve the liver even quicker.
Exactly. So the things we can change, you know, we've talked at length about this, discussing about our excess weight, treating your blood pressure, appropriately managing your diabetes, changing some of those habits that may be unhealthy and contributing to inflammation of the liver, including alcohol and cigarette smoking, both to prevent cardiovascular disease and to help your liver health. Sleep and mood, treating your psychiatric conditions if there are any, like depression, anxiety, really focusing on those things. In the sleep, I also think about sleep apnea. You know, a lot of our patients have this condition that's underdiagnosed and that plays a significant role, together with diet, which we've talked about as well as at length.
So Emily did a great job talking a little bit about weight loss. I mean, I think this continues to be a cornerstone, and you know, being able to reduce your diet, but still focusing on getting enough protein, fiber, vegetables, and really eliminating sugar and processed carbohydrates.
Yeah, you know, every dietary program has different approaches, and as we talked about, some maybe not be the right choice for fatty liver. And so I think that really focusing on making sure that the diet choice that you decide together with a nutritionist and with your liver doctor is the right one for you. But overall, if we had to put it in a script and give you an indication, you know, it would be something like really lowering the amount of calories, that's the amount of energy that comes with each meal, to about 500 calories a day or more. Up to about 1,000 calories is really what gets you to that goal of losing the amount of weight that you need. So, you know, working and assessing how much you're eating now, how much would be your target? What are those small changes that you can make over time to achieve those goals is important. And it would be an initial discussion with your primary care doctor, but then growing that over time with your nutritionist and everyone else involved.
So we've shown you a few times that, you know, that really weight loss works. And depending on how much weight loss you can lose, that how much effect we can see on liver improvement is really clear. So losing just a small amount, 3 to 5% of your body weight, can reduce the amount of fat in the liver, reverse it. And as you lose even more weight, up to 10% or greater, that's when we can see actually scar tissue of the liver improving. So again, weight loss is important. Even small amounts can be really important to your health.
And then again, you know, we know that diet is great, but if you pair that with exercise, then, you know, the benefits multiply. And again, the doctors, how do we prescribe exercise? How do we get patients to really start to think about this and move? Well, it's really hard. You know, everybody works in, their lifestyles are very different, and how they decide to exercise is very different. So what I like to tell my patients is that there's two major types of exercise. There's the aerobic exercises, and then there's resistance exercise. Thinking about running versus lifting weights, they're very different, right? And so in order to really think about NASH, we know that, again, that exercise, even though it doesn't lead to as much weight loss as we would want, even if it doesn't lead to weight loss, still improves fatty liver. So any amount of exercise both improves cardiovascular risk and improves the amount of fat in your liver. So again, if we had to put it in a prescription, these are the maximum numbers. You know, if you're doing moderate intensity exercise versus vigorous intensity exercise, would be up to 300 minutes a week. But if you think about it, moderate intensity is enough that makes your heart pump and you sweat. And 150 minutes a week is really 30 minutes for 5 days a week. So it's not as daunting as it seems. And you don't have to do it all. You can start very short, 10, 15 minutes a day is better than not doing anything at all. So little by little is an improvement. And if you have knee problems and you have trouble, there's all these different types of exercises that can still have your heart pumping and sweating, but still protect your joints and the issues where you might have. So definitely talk to your doctor and see what options are available for you.
And I think it's great that you pointed out that even without losing weight with exercise, that doesn't mean it's not working. You may not lose weight, but it's still really important.
And then, you know, we have highlighted throughout the day that there are no specific FDA treatment approved for fatty liver, but that's what we hope to change in the future. We've talked overall throughout the day of medications that you and your doctor, both with your hepatologist or your primary care provider, can discuss to improve fatty liver. We haven't touched base as much on vitamin E, which is really one of our cornerstone drugs. And we use it's in the guidelines to help patients who primarily though are non-diabetic, and we use it in patients who have a biopsy-proven NASH. But there were some preliminary trials that suggested maybe increased mortality, prostate cancer risk. So again, it's an important discussion. And then we've talked about some of the diabetes drugs, pioglitazone, metformin, the GLP-1 inhibitors like semaglutide and liraglutide, and gliflozins, and they all have their pros and cons. So I think it's important to, like Dr. Shorkar said, that really discuss and say, well, you know, of my diabetes regimen, or can there be any new medications that I can add to my regimen that may help improve my liver health? And then lastly is statins. We get this question asked all the time. Can I be on a statin? It says that if my liver enzymes are high, I maybe shouldn't be on it. And I want to stress that this medication is not only safe, but is also you know, important to prevent for prevention of cardiovascular risk. So yes, we discuss it, we watch carefully your liver enzymes, but you should not stay away from a statin because of previous health conditions.
So yeah, just to reiterate that again, you know, that there are no FDA approved medicines, which is why we're going to talk a little bit about clinical trials, but we do, as our speaker spoke about, in specific situations and in discussion with you and your doctors, we do have some off-label medications that we can consider. The newer kids on the block being the semaglutide or Ozempic, as you may have heard it, which also does have weight loss effect. Some medications, though, to be careful, not everything works. And you'll see a lot online, a lot of herbal agents that will say that they may be helpful. Milk thistle is a famous herbal agent that's been touted for the improvement of liver disease. You know, there really hasn't been significant data to show that. So again, talk with your doctor. If you have a specific reason to be on a omega-3 fatty acid, then that's something to discuss, but there's no specific liver improvement effects that have been seen. And then we're getting closer. We're going to talk a little bit more about clinical trials, but you know, I think Dr. Lagarde and I will both say this is a really exciting time in our careers because there's so many new medications getting very close to getting FDA approval that are going to be directly to target NASH. And so you can see I have 4 listed here of phase 3 trials that something that could be considered.
Yeah, so, you know, we want to talk about a little bit about clinical trials because it really involves participation with your doctor, and it really is involved from the patient. So when you volunteer to take part of a clinical study, you know, you help really us doctors, researchers, and just the general population learn more about your specific disease, and in this case, fatty liver. And hopefully it can get us to a point where treatment strategies are good, are available, and are safe. And so researchers right now are studying many aspects of fatty liver disease. For example, new treatments, but also genes that lead to fatty liver, and how does it progress over time, how it affects other conditions. So there's multiple areas where research is undergoing. And so, you know, how do the clinical trials work? Well, you have different phases, right? It goes anywhere from just thinking of a possibility and starting to do, you know, laboratory analysis on a disease, and it goes all the way up to ready for patient consumption on a day-to-day, in which case research doesn't stop. Even on medications that have been in the market for years, those are still being understudied and monitored to make sure that they're safe. So in each one of these categories, you know, patients can be involved in a clinical trial.
And I want to say, I know many patients get nervous about it being a guinea pig in a trial. That's a concern. You know, most of the trials that we're going to be talking about are late stage trials. You can see here, phase 2 or phase 3. So these are trials that have already been past that early phase. They've shown safety. So that's not a major concern. We're more at this point looking that these medications work. So you shouldn't feel as though you're putting yourself at a risk during these trials. We're here to monitor you.
Yeah, so, you know, what questions could you ask, you know, your research studies? What are we looking for in a trial to help answer through a clinical trial? So, for example, we may be looking for interventions. So there's 2 major classes of trials. Ones are interventional and ones are observational. what that means is, one, we're just looking at a patient who has a condition and just kind of recording their history and seeing where they are, whether it's through their physical exam or maybe even blood work. But really, we're not doing any major changes to how they are doing their life. We're just basically closely following. And then some are really interventional, which means we're trying to see if something we do for that disease works, whether it's medication, sometimes diet changes, healthy exercises. There's all these different things that we can try. And so there's a list of potential interventions for NASH here that you'll see. So for example, medications that can help decrease inflammation or weight loss, or stop the scar tissue or the fibrosis, but even also with some of our diagnostic testing, for example, is the elastography better than the MRE, or is there another new way of diagnosing fatty liver or scar tissue without having to undergo advanced procedure? So in each one of these, there are trials, and we need patient support for that. Yep, and again, we need volunteers from all kinds of the walks of life, from healthy volunteers, from patients with the disease, from all backgrounds and ethnicities, etc. So everyone really is welcome to be discussed. Now, how do you know if you qualify? Well, your doctor is going to really go through that before this is a possibility, and the research team. They're going to look at all the things that a trial may ask you, other conditions, etc., but also really commitment. Patient has to be willing to commit to the time for the trial, and they're, to be monitored very closely. And then, there are some exclusion criteria or things that would not make you qualify for a specific clinical trial, like having additional illnesses that may make you too sick to be studied, and sometimes even the possibility of being pregnant in the future. And so those are some of the things that you'll be asked. Lastly is, what if I want to, I was put in a clinical trial and I don't think I want to participate anymore? Well, this is all a voluntary process. So what you have to do is have that discussion with the doctors, with the research team, and you're always, this is not something that you're locked in for life. You can always walk away. It is important, though, that you have the discussion, and that if you're going to stop a clinical trial participation, that you let the team know. And then be prepared. If you're thinking about this as an option, there's some potential questions that you may want to have in the back pocket to discuss with the research team. Do I need to travel? How long am I going to be part of this study? How often will I have an intervention, or how often do I have to see you? And again, really discuss the benefits and risks for your particular case.
So again, there's a lot of really exciting things going on. And like Dr. Lagarde said, we're never going to be able to solve or find really good treatments for this disease without the help of clinical trials, because that's the only way that medications can get approval and access to patients. So we talked about a lot of the different mechanisms, NAFLD, NASH, cirrhosis, and I just showed this to more tell you that there are different targets, different medications that are looking at different ways. So depending on where you are in this disease, there are different medications that you may benefit from, or even a combination of medications. So it's a very exciting space and a lot of good therapies coming. I'm going to show this one therapy just as an example, and some patients here may have even been a part of some of the trial with this medication, obeticholic acid. This has been one of the medications the furthest along in clinical trials. But I show you this diagram of the liver, just to specifically show you how complicated this is. But what we're trying to find is there specific mechanisms, in this case, this FXR agonist, which is this receptor that can act on different parts of the liver to decrease inflammation, decrease triglyceride in the liver, affect sugar. So a lot of exciting work to be done. But again, these trials, when you enroll in one of these trials, you may be, as this trial has done, be put in a different group. Either you're getting different doses of the medication or even a placebo. So that is a possibility with a trial. But even in the case of getting a placebo, you're getting very close monitoring by your doctors and imaging. And in a disease without many other treatments, I think it's a really good thing to be a part of. So, just to kind of update you on what trials we're doing at Thomas Jefferson University Hospital, we have different treatments for cirrhosis, specifically for NASH, so without cirrhosis, but fibrosis of the liver, and then some observational studies where we monitor you over time. And there's different treatments, including infusions or pills or injections. And really meeting with your team will help to decide what would be the best treatment for you and have a discussion.
Same at Einstein Healthcare Network. We have a team of researchers that help us identify patients. And then from there, in a discussion with your doctor or myself directly, we really think about which trial is best for you based on what you're willing to do and participate, but also what would really be best in your stage of disease. So again, we have observational, meaning we just do blood work and check some inflammation markers, or we look at your body composition, how you manage fats and your weight and the calorie counts. But also we have pharmaceutical trials in which you may take a pill for a period of time. And so again, it all depends on what you feel comfortable with, what is right for you in this stage of your disease, and what you decide with the team that's helping take care of you.
So great. Really, I think we just wanted to let you know these are options for you. And if you're interested, either both myself or Dr. Lagarde, we would love to see you for an appointment. So you have our information there. But if you'd like to just specifically get some more information from a coordinator, we can provide this information. You can email them directly to ask about trials.
Very good. And so now we're going to be moving ahead with our program. We're really on the last stretch. So the next part was really recorded with Ryan Healy. He's our addiction specialist here on Einstein Healthcare Network. And unfortunately, he wasn't able to be physically here with us today, but what we did is a couple of days ago, we recorded kind of an interview with some of the common questions we get regarding alcohol safety and fatty liver. And so we wanted to bring that to you. We try to make it a little bit more interactive and one-on-one. So I hope you enjoyed this video, and then we'll for sure be able to answer questions about this as the Q&A session comes on. And hang on tight because the more prizes are coming. Good morning, everyone. My name is Maria Lagarde, and we have been talking throughout the morning. Thank you for joining us for our Fatty Liver Symposium and Patient Education Program, hosted by both Einstein and Jefferson today on Saturday, October 15, 2022. This is recorded a couple of days before, and I want to thank everybody for joining us today. As the last part of our program, we have Ryan Healy in an interview form with myself, Maria Lagarde, talking about alcohol safety and addiction counseling. Ryan is our substance abuse counselor from Einstein Healthcare Network and from our transplant program, and he has agreed to participate in this discussion with me today. Thank you, Ryan, for joining us.
You're welcome. Hi.
Hi. So let's first talk about why do we think that it's important to discuss alcohol in a fatty liver symposium directed to patients?
So it's a good question, Maria. One of the things that that we know about fatty liver is that alcohol can contribute to it. And the one thing that you want to differentiate between contributing or people who drink and people who drink excessively. I think one of the big factors with fatty liver disease could be, if someone's drinking too much alcohol versus someone who is, drinking socially, drinking 1 or 2 beers here and there.
Yeah, very good. And as we have talked about throughout the day, we know that fatty liver can be associated with excessive drinking in and of itself. And so it's important to really make this distinction. So thank you for guiding us through it. So
Absolutely.
Let's start talking about, how commonly is alcohol a problem? So why are we worried about alcohol consumption?
So alcohol, 5% of deaths in the US are directly related to alcohol. 13.8 million people in the US have alcohol use disorder. It's since the pandemic, it's gotten bigger. It's a growing, it's an epidemic of its own, where a lot of people are being affected by it. It's something that, people accept regularly. So it's important to recognize that.
Great, thank you for bringing that. Yes, we know a lot of people have alcohol use disorder in the US. It's associated with a higher risk of death, not only because of liver disease, but also because of accidents and trauma. And so it's important to recognize that in the US, alcohol drinking is a problem. And of course, we have to direct it towards fatty liver and the presence of liver damage, but it's not the only reason that alcohol causes death. So thank you for that. Why do we have to talk about alcohol as we spoke about in a fatty liver education session? So we mentioned that earlier, right?
Right.
So we have to make the distinction between patients who drink and have fatty liver because of the alcohol, and then we have to make the distinction between patients who their fatty liver is not related to alcohol. And so it's important to make that distinction. All right, so this is a very important question that we always get asked. So what is a safe amount of alcohol that a patient is allowed to consume?
So that's a great question. So if you just go to the next slide, you can see the different types of alcohol and how much is in each one. So 12 ounces of regular beer contains about 5% alcohol. Table wine is about 12% alcohol, and 1.5 ounce shot of distilled spirits contains about 40% alcohol. So depending on which alcohol you choose, depends on how much of the percentage of alcohol is in it.
Okay, and is there a difference between how much a man or a female is allowed to drink on a regular basis? And is this allowance once a week or once a month? Like, what does that mean for patients?
So there is a difference between men and women. Women are allowed about one standard drink a day, whereas men would have about 2 standard drinks a day, if given that they're healthy. Patients that are pregnant or liver disease or any other, no alcohol would be best. And this is to reduce, the risk of injury.
Yeah, exactly. I think it's important to make that distinction that if you're healthy, that might be the top most amount of alcohol that it's safe to consume. But if you're not healthy or you already have liver disease, that may be just too much. And obviously, there are situations in which drinking is never a good thing, and that includes being pregnant, breastfeeding, or patients who are under 18 or younger adults. All right, thank you. So how about if I only drink on the weekends? Is that still a problem, Ryan?
So this is a great question, Dr. Lagarde. I think that this is a question I get a lot. I think one of the things is, patients usually say, "Oh, I only have one drink a day," right? So they have one drink a day, and one patient could have a drink this big. Another patient could have a drink this big, and it's the same thing about weekends. If you have a risk, if you have liver disease, if you have any other real medical issues that alcohol could put you at risk for, I would suggest not drinking during the weekends. But if you're drinking on the weekends, it depends on what you mean by drinking on the weekends. So, binge drinking is 6 to 8 units in a single session. So, some people do binge drink every weekend. If you're not drinking Monday through Friday, but then you're drinking what you would have drank Monday through Friday on the weekends, it could be a problem.
Yeah, and we know that binge drinking is associated with liver disease, with fatty liver, as well as with acute toxicity from alcohol. So recognizing binge drinking is also very important. And this is just a marker of how much you have to drink to get to a binging session. So we put this up for patients to recognize that a lot of patients do this, they all kind of pile it up and drink everything in a single session, and that can be as harmful, if not more, than drinking, spaced out through time. Not that you still have to make sure that you keep it under the concerning amounts that we have talked about before. Okay. So what may a patient recognize, or what are some things that they may identify that maybe their drinking behavior is starting to be a problem?
So there are some indications that drinking too much, consuming more than you anticipated, trying to stop without with physical effects, without success, multiple failed treatments, dangerous situations, missing work. There's a lot of factors that go into, indications that you're drinking maybe too much.
Okay. And if you had to tell a patient, look for these things and see if this has happened in your life, what would be some of those key signs that would tell you maybe this is becoming a problem in your health?
So trying to stop without success, consuming more for a longer period, like I said, this is a great slide too, because, poor concentration due to alcohol cravings, consuming more despite having mental health issues. These are some of the factors that you really look back on and you think, is this a problem for me?
Yeah, and it's also important to recognize that if somebody has been exposed to a medical professional and they have been, that drinking has been a part of the discussion with that medical professional, and it has been highlighted as maybe causing some health concerns, then that's also a very key indicator that maybe your drinking is out of proportion to your health. All right. I have another question for you is then how do medical practitioners or, physicians, physician assistants, you as a substance abuse counselor, did you identify that a patient has what formally is called as an alcohol use disorder?
So typically when a patient comes into our clinic or our hospital, the first thing I'll do is introduce myself, and then I'll present them with, a questionnaire, and I'll ask them. I'll ask the patient. Sometimes they're too sick to kind of read or write, so I'll read it for them and have a conversation generally about what's been going on for them. And as you'll see on the next slide, there's the whole questionnaire of, how often do you drink? Do you have drinks containing alcohol? How many standard drinks? And these are scored. So, the more that they're scored daily, weekly, or monthly. And so the higher the score, obviously, then, the more indication of an alcohol use disorder.
Okay. Yeah, we use multiple of these tools. There's some shorter ones, some longer ones. Every practitioner is more comfortable using different scores, but this is really just a highlight to show patients that these are the things that we're concerned about, and these are some of the questions that you may ask. And if you start to score higher on those parameters, then you may want to, either talk to your practitioner or even just, discuss it in the office as starting to become a problem. And I also wanted to mention, I know that there's some of these are available online. So could a patient just go online and fill some of this out for themselves if drinking is a concern?
Absolutely, they can. And I was also going to mention too, like there's so many, and you had said there are so many different assessments that, self-assessments, administered assessments. There's a SALT score, which I really like, which is something that, we use for transplant as well, as the audit, but patients can always go on and take their own assessments to see, because, obviously the first step in any kind of problem is recognizing that there's a problem. Okay. And having them explore these and see that this is something that could be impacting their life negatively.
And just looking at the news, I did wanted to bring this up because it comes up so often now in medical literature and, in our day-to-day lives. And as you can see on this news clipping, how do you think COVID-19 pandemic has affected our alcohol behaviors in the US? I recently came across this article, and, Pennsylvanians were buying record amounts of alcohol in the last 2 years. So how do you think this has made an impact into, liver disease and alcohol consumption?
Yeah, absolutely. I think COVID, really has increased, unfortunately, the prevalence of alcohol use disorder in Philadelphia. I think sales were up 400%, liquor and alcohol sales in general. And, the occurrence of alcohol use disorder has gone up significantly too. And I feel like the amount from the isolation from being, at home, working from home, many people were having like Zoom parties, and, there's no risk of, having to drive anywhere or going out to bars or anything like that. So people were drinking more. And, now that things are kind of a little more lax, people are still stuck in that cycle of drinking as much as they were when they were by themselves.
Yeah, it's really concerning. We've been definitely seeing an increase in patients who come in with acute alcohol toxicity, chronic changes from their drinking patterns in the last couple of years. So it's definitely something to recognize. And there are, as you said, multiple factors that are participating in this, but the isolation, the lack of social support for the last few years, loss of employment, increasing signs of depression and anxiety because of illness and economic situation. So all these factors that are playing a big role, and where alcohol has become, unfortunately, kind of like a crutch for patients to deal with these issues. And that's concerning. There's a projection in this slide where, there was a recent paper published in Hepatology showing that it's expected that the behaviors of drinking in the last couple of years in the US are expected to increase liver-related death coming up to 2040. So those projections are really concerning, and it's important to try to stop those behaviors now instead of waiting for them to continue to progress.
Absolutely.
So a patient now identifies, I think my drinking is a problem. I've gone through some of this. What can a patient do? What would be the next step?
So, and again, this is a lot of my day, is, you know, when a patient identifies that they have a problem with drinking, there's so many different avenues that they can take in order to treat their alcohol use disorder. You know, there's inpatient settings for people who need to get out of a current environment so they can get away from the situation so they can stop drinking. There's outpatient where, you know, people who have to work and support their family, but still want to get treatment. They can go 3 days a week for, you know, 2.5 hours at night. And they go through your insurance typically. They can also go to AA or NA or, you know, any support group. We have a liver transplant support group. Support groups are everywhere and they're free. So they are something that I highly recommend to people. And they've shown to you know, really help people. So there's tons of different avenues that people can take, because treatment doesn't have to be, you know, a cookie cutter situation for people. You know, not everybody wants to treat their alcoholism the same way, but, you know, ultimately support and professional help can be something that'll help people.
A question that I always get is, do you have to have advanced liver disease in order to participate in these programs? Do you have to have liver damage in order to be a candidate?
Absolutely not. Absolutely not. Anybody can call and join, and yeah, it's something that's people without liver disease have alcohol use disorder, and they need help just as well.
Yeah, I think it's important to recognize, you know, you may not be at the end of the line. You don't have to have liver damage and all the physical complications of liver disease. But if you have an alcohol use disorder, you have recognized your drinking pattern as a problem, as an addiction pattern, then, you know, you can seek help before it turns into a physical problem and before you have damage to other organs because of this. So I agree. I think recognizing the problem is the first step, and then looking for help when you can and where you can. So where could a patient seek help?
So they can actually, so looking for places, I mean, they can, typically a lot of patients come into the ER for detox, you know, and then they detox in the ER, and then they're kind of referred other places. There's places that you can go and just show up and they'll take you in for detox and inpatient rehab. There's, you know, you can call the back of your insurance card. You can talk to your doctor. There's medications. You can go to different support groups, as I mentioned. So there are ways to get help. There are ways to seek help.
Yeah, I always tell my patients who are struggling with this is the first step may be just right around the corner. Your general practitioner, your you know, your local church or your local community group. And they may have a ton of resources that you may not be familiar with that they can access. Obviously online, there's a ton of resources, and we put together a little bit of a summary of some of these resources, but there's a million more. And so even though you feel alone and you feel like there might be issues with addiction, that it's really hard to get help in the community, there's actually a ton of resources that are available.
Right.
Okay. Any other final comments that you may want to share with our patients? Any other suggestions or recommendations?
Don't be afraid to ask for help. I mean, I think, you know, you're not alone. You're not the only person who's gone through this. And I think, you know, it's important to understand that you're not the only person.
Okay. Well, thank you, Ryan. I really appreciate your time and taking this time to talk to me. And thank you, everybody, for joining us at our Fatty Liver Symposium and a patient education program for patients with fatty liver. We'll be back to our regular programming with the rest of the team online. Thank you, everybody.
Thank you.
Bye.
Thank you, Dr. Lagarde, for recording that so that we didn't miss that great interview on that really important topic. I want to invite all of our speakers. We're a little bit close on time, but I think it's because we all got so excited about this important topic and providing information. But if all of our speakers want to turn their cameras back on, we'd love to answer some questions. I'm going to go first, actually. Emily, I have a question for you. So, you know, you talked a lot about avoiding sugar. What about fruit? You know, I know, although, you know, fruit is something that people worry about in terms of sugar intake. Any concerns or anything specific people should be aware of when they're eating fruits?
Yeah, so a couple interesting facts about that. I always have patients that will come to me and say, I'm not going to eat a banana, but yet they'll eat ice cream and cake. So it sort of doesn't make sense. That being said, if you're diabetic, eating large, and if you're on insulin or one of the medications, insulin lowering medications, or even trying to prevent diabetes, if you're eating a whole lot of fruit at one time, like if you're eating a banana and grapes and watermelon, like large amounts, your body can't process that amount. So having fruit is okay. You just want to have it within the portion size, and you want to have it throughout the day. There's been studies showing that actually eating fruit does have an anti-obesity effect. So it's very important because it has antioxidants and fiber and things that make you feel full. So having it is fine, and always having it in a fruit version, chewing it versus putting it in a smoothie or putting it in a juice. Because again, smoothies, if you put 8 pieces of fruit, you're having this concentrated amount of fruit, which again can spike blood sugars.
Great, thank you.
Yeah, we have another question that was sent in preparation, and I think this is really important to discuss is, is there anything specific that is there any specific nutrient or supplement that can be used to break down the fat in the liver? And, I think that you touched base about that a little bit, about there not being specific treatment, but or a specific thing to approach, but I think it's really important to hunker this down and really put the message across. And that's a question for Emily.
I'm sorry. I know if it was a medical question. So yeah, I always say, if there was a quick fix for any kind of pill to break down the fat or break down calories or, whatever, who wouldn't be on it? You know what I mean? So there isn't, and again, it's in the medical perspective too, taking these supplements can actually have a lot of side effects. Even there's one that they came out a few years ago, it's prescription, now it's even over the counter. It's called Ally, which causes fat malabsorption, but, it causes horrible diarrhea, leakage. There was a joke that one of the doctors said, if you're going to take this particular over-the-counter supplement, make sure you wear brown pants because you're always going to be leaking. So again, there's not one safe medication out there. Again, it's old school or just lifestyle modification. As well, I don't know if anybody I talked a little bit about, vitamin E or a daily supplement, and then all the different kinds of, I think, future studies with some of the supplements. But no, what breaks down fat is really, calorie restriction or eating less and moving, exercise.
Great. I have a question for Dr. Tartarian. So you talked about all the great benefits with bariatric surgery. What about a patient who already has cirrhosis of the liver from NASH? Would you still recommend it in that case?
That's an excellent question, and something I didn't quite touch on in the talk. So that would require, it's definitely possible, but all the more reason to have a really informed discussion with your surgeon and with your gastroenterologist, hepatologist. There's a lot that goes into play. Is there the presence of any kind of portal hypertension, high blood pressures in the liver that would increase your risk of bleeding, any evidence of varices of either the stomach or the esophagus, how well do platelets function, so exactly how severe is the cirrhosis, and at lower stages, surgery is still an option. We may favor sleeve gastrectomy over a gastric bypass, though, in those patients, because in those with cirrhosis, we have seen that a gastric bypass can actually cause worsening encephalopathy and maybe even make the liver disease worse. We have new data that's showing that patients that may need to qualify for liver transplant, we're doing bariatric surgery on some of those patients with high BMIs to make them eligible for transplant. So we are operating on sicker and sicker patients. So I would say it's definitely worth the discussion.
Yeah, thank you, Dr. Tartarian. That's always a question that comes up in both practices. I have another specific question for you. Is there an age limit on bariatric surgery? So a lot of our patients, with multiple metabolic conditions start to, get older in age, and that question comes up quite frequently.
We do not have a technical age limitation. And this is something that has changed over years. And as we've kind of perfected our technique, and as we see those outcomes have improved, we are no longer limiting the age. So we have patients in their 60s and 70s. I think probably mid 70s is the highest I personally have operated on, or that's come to my clinic for an operation, but I wouldn't discriminate based on age, as long as, your other medical conditions are reasonably controlled and it's safe.
Great, thank you. I have a question for Dr. Abanka. So, you know, you talked a lot about statins. It's great to know that patients with liver disease can safely take these medications. But what about the patient who is still intolerant to statin? I know there's some other new medications out there. Is there anything you would recommend for that person? And then a follow-up question would be, what about fish oil? It seemed like that was all the rage, and now I know it's been questionable in fatty liver as well. But if there's benefit in cardiovascular disease.
Sure, thanks for the question. So first part, addressing statins. A lot of patients have intolerance to one of the statins, but may not be intolerant to all the statin medications. It's often a trial and error process. And the symptoms that people have of muscle aching and soreness may be attributed to statin, but they also may not be. So sometimes people think they are intolerant of statins, but after exploring a little bit more, it may not be the case. There are medications for patients who are intolerant to statins called PCSK9 inhibitors. The drugs are named Repatha is one of the particular drugs that we use for patients that either are truly intolerant to statins or are not reaching their goals despite being on a statin. They're really powerful LDL lowering drugs, and they are injectable, so that put some people off of them, but they are very effective in lowering the LDL. Are they as good as statins? We don't truly know the answer to that because the long-term outcomes are not studied as well as statin. So far, we really recommend statin as the first line agent. Fish oil is kind of adjunctive or add-on therapies that we do to a statin specifically to lower triglycerides, and that can have some added benefits, but the main goal that we really want to achieve is lowering LDL in the first place. So once we get there, we can fine-tune it further with fish oils and other medications.
Thank you, Dr. Abanka. And that's an excellent question that we always come across as well. I have a question about, just really for patient knowledge, is differences between presentation of cardiovascular disease for women and men, and specifically with such big population of diabetics. Are there any differences of the typical presentation that patients might have heard on the news or in information sessions?
Absolutely. Thanks, Dr. Lagarde, for asking that question, because there's always a great chance to just talk about this issue. The classic chest pain that we describe in patients is not classic, really. It's only occurs in a minority of patients, and it is more classic in men than in women. Women have what we call atypical chest pain, which may be not chest pain, it may be fatigue, shortness of breath, neck pain, back pain, jaw pain, things like that are not really the classic hand over your chest kind of symptom of angina that we talk about. And also in diabetics, the symptoms can be very subtle. So if patients have a lot of risk factors, they should definitely try to be aware that a symptom that's new and is coming on and is something like what I described, it should be evaluated. I do see a lot of people who have waited on their symptoms, and unfortunately we say time is muscle, and if you're having a heart attack, it's important to get it addressed as quickly as possible. So change in exercise tolerance is also something where patients, they're exercising and say, well, I can't do what I could do a month ago. That may be a sign that you're having a heart problem and it could be checked out.
Thank you. Thank you. I have a question for Dr. Schrodekar. We've been hearing a lot about this new medication. I think hopefully I'm pronouncing it right, Mounjaro. And so I wanted to get your thoughts on that. You know, you talked about the weight loss that now we can see with some of these diabetes medications, which is really exciting. What's your thought on that medication? I know probably a little too soon for fatty liver, but is that something our patients should be thinking about or looking into?
Yeah, that's a great question. I think I had it on the slide, but maybe I didn't get a chance to touch on it. So it is along with the GLP-1, it's a combination GLP-1, GIP-1 hormone receptor. So it's adding on an extra gut hormone, and the results for weight loss have been really impressive. And so it is approved right now for diabetes. Unfortunately, for my patients, it's a little bit more challenging to get covered. So we have had a handful of patients that have done fairly well on it. Some have some side effects, typical, similar to the GLP-1 side effects. But I think in terms of weight loss, it is better than just the GLP-1s. And the New England Journal article highlighted that. So up to, I think, 72 weeks. It was pretty impressive. I can't remember the exact weight loss, but it was a significant amount greater than the GLP-1s. So hopefully we will see that, and we'll eventually work with obviously fatty liver just because of the weight loss effects. And then once again, at some point, I guess if you have biopsy result type of studies, that'll be great. So it is Monjuro.
Great.
Yeah, I have a question for both Dr. Shadakar and Dr. Halegua too. Sorry.
That's okay.
The most important thing is, a few of our patients ask, well, what if I don't really have some of these risk factors? I'm not obese. I don't have maybe all the metabolic conditions. How come I have fatty liver? And I don't think we've talked about some of these like very specific type of patients that may be outside of all the discussions we've had today.
Dina, I don't know if you want to go ahead and start on that one. Yeah.
I'm sorry, I was answering somebody in the chat. Can you answer one more time?
No problem. It was really about, what happens with these patients that don't really fit the metabolic profile type picture. They're not diabetic, they're not obese, maybe they're outside of all these discussions we've had today. And
the lean
how
NASH.
come this happened to me?
Yeah, I hear that all the time. We call it lean NASH. And I'd be interested in Dr. Shodakar's thoughts too, but my thought is that they are still insulin resistant. Although you may not, your BMI might be, below 25 and you're not diabetic by definition, the liver itself is still insulin resistant. And I think that's important when we were talking about how this disease occurs, that's still happening, and healthy lifestyle can still fix the condition. So, and exercise. So I would still treat it the same way, maybe not focusing so much on weight loss, but more just metabolic treatments. I guess it's certain ethnicities, this will be really specific. And I would say Asian ethnicities, sometimes they're thinner people, but still can have, pretty significant diabetes or insulin resistance.
Yeah, I agree. I think we do see a subset of patients that are thin and they just have some underlying insulin resistance, maybe genetics that we're not fully aware of yet that contribute to this lean model of metabolic syndrome. It's not extremely common, especially because obesity is so much more common these days. But I do agree that certain ethnicities, Asians especially, tend to have lower BMI cutoffs, and they might be thin and their weight might not reflect some of that insulin resistance, but you see those thin patients even that just have that visceral fat and visceral obesity, and their numbers might not look like they have a very high BMI, but those aspects, those clinical aspects, do show that they have some insulin resistance and are predisposed to these metabolic diseases.
Yeah, I agree. And there was a recent guideline proposal that even in this particular subset of patients, still really targeting metabolic risk factors and even a smaller amount in proportion, but still targeting weight loss and increased exercise modifies that insulin resistance and your body's ability to manage sugar and really helps decrease the progression of fatty liver. But they are harder to recognize. And so, really considering that if you have these risk factors, you really should talk to your doctor and really think about the possibility that this may be happening in you is really important.
And just a quick
That's it.
point on that as well. And the agents that we use, so whether it's Actose or Ozempic, even if they don't have diabetes, remember they can help with fatty liver, and they should not cause hypoglycemia. And that's key. So you can get the benefit if you're pre-diabetic or even in that sort of lean, non-diabetic category, they might still be very beneficial.
That's a great point. And Dr. Lagarde, that was a really good point about that group of patients in that recent study that, bringing Dr. Banca back into this, that they may actually be at higher risk of cardiovascular complications. So, definitely an important group to, really realize, even if you're thin, you can still have NASH and significant disease. Well, I guess we're actually out of time, but I'm going to ask one more question to Dr. Lagarde, and then we can close. There was a question about having pain from fatty liver. So, either back pain or right upper quadrant pain. What does that mean? And can that be a symptom?
Yeah, so that we get, this is a very common question in our practice, and it really comes down to a few things. The liver in and of itself, the liver cells, they don't have really nerve connections. And so the liver in and of itself does not hurt. What hurts in the liver is the capsule or this sac in which the liver is enveloped. And that's where all the nerve connections are. And so if there's concern for liver pain, that happens when the liver either grows in size very quickly or close to that capsule, there's active inflammation. So it tends to hurt if it's very actively inflamed or it has grown in size significantly to the point where it causes pain. So this particular disease may have absolutely no symptoms, may cause no pain or discomfort unless some of these signs are happening. And we see this in patients who may have a quick progression or their metabolic conditions rapidly change, or they have big changes in weight gain or weight loss over a short period of time in which the inflammation may be happening really quickly. And those are the patients who may have pain or discomfort. And so especially the patients in whom you can feel the liver on the outside, they tend to have more pain, but that's not always the case. And you still have to look for other reasons to have pain, because pain is not the typical reason. This is not a typical symptom of this. So I think that's important to recognize this. If you're having pain, we have to look for other problems.
Perfect. Well, thank you again to all of our speakers. This was such a great day. Hopefully our patients learned a lot. We did record it so they can go back and use this as a resource, and hopefully will be really helpful. So thank you so much. And that will conclude our program. Again, want to really thank our sponsors, the American Liver Foundation and Community Liver Alliance, for collaborating with us.
I want to thank our coordinators. They did a wonderful job today at keeping us somewhat in track with time and other things, but really thank our sponsors, our coordinators, our patients, who really are our goal here is to really get you in our healthy liver health as much as we can. So thank you, everybody.
Thank you, everyone. Have a great rest of your afternoon, and we look forward to seeing you again soon.
Thank you. Take care.